we have learned for the findings of hypokalemia, especially from the ECG perspective. I'll just zoom into this particular ECG where I have pointed towards lead number 2. And what you can notice is this is a P wave which looks slightly taller than what it normally should be. And then there is a visible ST segment depression. Once the ST segment depression is visualized, I'll just do a ink change here to show that there is also concomitant T wave inversion. This in green that I've shown is a T wave inversion. Now comes a very peculiar finding and is one of the main reasons why I am doing it on a real-time ECG, that is presence of a prominent U wave. Remember, I had told you the fact that U wave is found in a ECG of a normal person due to a delayed repolarization of papillary muscles, but here I'm pointing at prominent U waves. As far as these color changes are concerned, I have done this once again. ST depression that I am showing in red, then is the green, which is T wave inversion, and the yellow there is representing a prominent U wave of the patient. And there is a possibility that in the exam it might be a little difficult for you to pick up. So what I'm pointing to this or why I'm showing this ECG is not because that I want you to pick up a prominent U wave, but rather a arrhythmia that can be seen with patients of hypokalemia. You see, when I was teaching you hyperkalemia, I was saying that there could be a diastolic arrest in a patient, or rarely in hyperkalemia, you might even be having a ventricular fibrillation. I'll just put that on record. Hyperkalemia usually causes bradycardia. It causes finally a diastolic arrest in the patient. But the tachyarrhythmia which can be seen with hyperkalemia is ventricular fibrillation. Now let's look at this person's ECG, which is showing broad QRS complex. The RR interval of this patient is also reduced. So my interpretation at the moment is that it looks something like a ventricular tachycardia, but there's a problem to it. The problem is that the amplitude of all these QRS complexes, if you compare the amplitude of the QRS complexes at the two black arrows that are made on the slide, you will notice that it is actually not the same. So my interpretation here is polymorphic ventricular tachycardia, and this is the main reason why I'm going into this topic, that polymorphic ventricular tachycardia is a tachyarrhythmia that can be seen due to patients who are suffering from hypokalemia. This can contribute to death, but if he says overall what is the leading cause of death, now look at the change in the vocabulary. I said there could be a tachyarrhythmia seen with hypokalemia, for which I've also discussed the correction values on my previous slide, but at the moment I'm teaching you the leading cause of death in hypokalemia would not be answered as polymorphic ventricular tachycardia. Then your answer would be muscle paralysis. And which muscle paralysis? Your answer would be diaphragmatic paralysis. This is going to contribute to severe hypoxia. The carbon dioxide values will increase. Patient will end up in carbon dioxide narcosis, respiratory acidosis, and finally will expire. So you can see hypokalemia, why it is asked by the examiner, because he can ask you regarding the tachyarrhythmia which is seen in this case. He can ask you about the diaphragmatic paralysis, and obviously in the same question, I'm not talking about different questions, in the same question, the integrated variety, he can also make you do this one-step calculation that I was teaching you earlier. And once we have done this, to put the cap on the electrolytes and ECG component, I would also like to utilize this opportunity to mention about drugs which are used in hyperkalemia. Like for the chronic variety, I can say he could give you a situation of a patient who is chronic kidney disease, let me say grade 4, because usually potassium starts rising once the patient progresses from grade 4 to grade 5. Now there are multiple drugs which are used here, and I would suggest you to listen to the CKD topic which is given in the kidney section main app to get into more details of it. At the moment I'll be just focusing on the fact that this patient of mine who has still not decided whether he would like to go for kidney transplantation, and his potassium values are spiking. Now one option is I can go in for a hemodialysis in this patient and I can get this potassium back to normal, but over and above this I also need to use drugs. All patients may not have been initiated on hemodialysis, and all patients may not be able to, or may not be willing for it also. So what are the drugs that you can use for chronic hyperkalemia? Then the drugs to be remembered here would be one, patiromer. The textbook will use the word novel agents per se. So first answer that you would be giving for the chronic version is patiromer. Then there is another one which would be called as sodium zirconate, and the third one actually is a resin. So if you're using the previous version of the app, I was talking about K-bind. The brand name is K-bind, and that is a resin that is sodium polystyrene sulfonate. We can use it in two formats. One could be, the oral format, or it could be even in the form of a enema. And this K-bind sodium polystyrene sulfonate resin had a couple of side effects as well. I mean, though they're relatively rare, it could have resulted in colonic necrosis as well post the enema component. So we are using the safer agents or novel agents which are mentioned in point number 1 and point number 2. As far as the acute onset hyperkalemia is concerned, that's a hot favorite of the examiner, and you would be familiar about answering for acute onset hyperkalemia from even your pharmacological domain, because you shall be using calcium gluconate in this patient. The logic is pretty straightforward. Calcium causes contraction, so you're trying to antagonize the effect caused by potassium. Potassium is relaxing the heart, calcium is going to be causing a contraction. I can be using calcium gluconate. Though, just to trick your mind, he may not give you calcium gluconate in the options. He might say calcium chloride, but definitely not calcium carbonate. I'll just write it separately. Definitely not calcium carbonate, the one that is present in osteocalcium tablet, and we prescribe to our patients who are having, let me say, osteomalacia. So calcium carbonate is an oral salt which is present in calcium and vitamin D tablets, but here I'm giving a IV prep that's going to be calcium gluconate and calcium chloride, either of the two, whichever is available. In fact, calcium chloride is even more efficacious. Now, the problem with calcium gluconate is that it does not send potassium inside the cells. It's only to antagonize. So what I'm going to do next to antagonize, or rather I would say what I would do next step would be to send potassium into the cells, and therefore I can be starting my patient on an insulin drip. This is going to cause potassium influx into the cells, and the potassium values will begin to reduce. In fact, this would be highly effective drug that decreases the potassium values. Now, once I've done that, I can also be using furosemide, and the difference between point number 2 and point number 3 is that furosemide would be causing a urinary loss of potassium. So I'm writing the word caliuria. The fundamental difference between point number 2 and point number 3 that I've written on the slide is that 2 is causing a redistribution of potassium, and furosemide in turn is actually causing a potassium loss. Now, coming to point number 4 here, which means that I have exhausted all these resources. I have used all of them, and still the potassium values are either not coming down, or even if they came down, they're rebounding again after a few hours. So I'm left with little options now, and the little option that I'll have now will be highly judicious, highly effective. That is going to be hemodialysis. So if the question's language is like this, that if he says, which of the following is the most effective method? Now look at the terminology, pay attention to the words here. If he says, which of the following is the most effective method to control hyperkalemia, the answer would be hemodialysis. But if the question is not using the word most effective method, but is rather using the word most effective drug, then the answer will vary. I mean, as I mentioned to you, that insulin is going to cause potassium to go inside the cells, and to supplement this in point number 2 only, I will add, to supplement this in point number 2 only, what I can also use is salbutamol. Now, traditionally, salbutamol is read for management of asthma. In these patients, the dose of salbutamol that is used is almost 4 times higher than what you use in asthma. What this salbutamol causes is excessive sympathomimetic stimulation, and the logic is that when you have a sympathomimetic stimulation, sugar values will rise, and when sugar will rise, it will cause a endogenous insulin to increase. You see, what I'm causing is excessive sympathomimetic stimulation, sugar goes up, endogenous insulin levels will rise, and once the endogenous insulin levels will rise, potassium will start going inside. This is precisely the reason why it is written in the textbook that salbutamol supplements the insulin drip component, because you see, if you use too much of insulin drip, you might even have a dangerous hypoglycemia, though you're using 25 to 50% dextrose along with it. But the point is, to neutralize or prevent that from happening, what we do is use salbutamol in the patient. The primary logic is that this will cause endogenous insulin values to increase, because you are giving exogenous, that is from outside. So that would be a strategy for point number 2. I have mentioned 2 drugs simultaneously, insulin drip plus salbutamol, which contributes to excessive sympathomimetic stimulation and causes a rise of sugar. And drugs useful for management of hyperkalemia, I mean the acute version of it. No, this is, I would say, bread and butter for you. Any entrance exam you get it, even in INICET May, Even in a simple INISET exam, they decided, instead of asking some hi-fi question, they decided to ask you about the standard management. And one of the options there was magnesium sulfate. I mean, a lot of guys, after the paper, they were laughing and they were saying, sir, we went with, some great concept is going to be asked. And all they asked was simple magnesium sulfate, which is not used here. I mean, where do we use magnesium sulfate? Then magnesium sulfate is used therapeutically for management of torsades de pointes, and I did showed to you that torsades de pointes would be seen with hypokalemia. Just go back to the previous slide if you get a visual memory of this, that one that I've just shown right at the moment, where the main issue is that there is a variation. I mean, this is a variable amplitude of the QRS complex, which is relatively broad. And I would also like to draw your attention to the fact that I did talk about varying amplitude even in electrical alternates, but then the situation would be different. There would be fluid outside the heart, there could be concomitant tuberculosis history or a trauma history given in a patient, whereas for polymorphic ventricular tachycardia, the only thing that you're gonna get is crushing patient. Dangerous hypokalemia, I mean, he might tell you the person might be having secretory diarrhea, and that secretory diarrhea patient is having very low potassium, outrageously low value 1.5, the BP crashed. What really happened was development of torsades de pointes, for which you will have to defibrillate the patient, unless I mean, if that is not done, the person would expire in the next 4 minutes or will become brain dead in the next 4 minutes. Now we come to another component of the ECG, that is to talk about bradyarrhythmias. I personally find them very fascinating and also relatively easier to comprehend. Because one thing that, I mean, when it comes to bradyarrhythmia, the number of squares that are present between the R and the R interval are so many that it gives you a breather actually. You get opportunity to evaluate simultaneously. While you are counting this now, you will also be looking at, is the P wave present? And I could not decipher the P wave. I mean, at this point of time where I put the green arrow the second time, this looks like an inverted P wave. That means there is some problem with the SA node, and then again the P wave has disappeared. Now this is again a situation where I would say absent P wave is being discussed. Before I make a mark of what is the condition that is being talked about at the moment, I would just like to remind you that there are two times that I've taught you absent P wave would be present. I hope you remember. One is for atrial fibrillation and second is going to be a patient who's having hyperkalemia. Remember, in hyperkalemia there was tall tented T waves with absent P wave. Now, what's the problem in this patient? The problem in this patient is that the heart rate of this chap is hardly close to 50, which means the fact that the SA node would not be functioning properly. SA node should be firing at a rate of 60 to 100. Here, SA node is not the boss of the heart. It is not able to fire. So my interpretation in this case would be a sick sinus syndrome. The problem of this patient is that the SA node is malfunctioning, and as a result of it, the heart rate of this patient is only 50. Is this going to compromise with the lifestyle of a patient? Well, I would say that it's not going to affect daily activities like maybe reading a book or maybe getting up and going up to the bathroom. That may not cause problems. But if this person tries to exercise, if this person tries to carry a 5 kg weight of vegetables, like weekend market, and he's procured vegetables from the market, if this particular person tries to carry it upstairs, his heart will not be able to generate the required increased amount of cardiac output, and there might be a syncopal episode on especially exertion in these patients. So I am beginning the bradyarrhythmia topic by describing before you what is called as SSS, that is sick sinus syndrome. Now in sick sinus syndrome, another very peculiar problem comes, which was asked actually in the FMG exam. And honestly, I did not anticipate that they're going to ask this particular ECG in the FMG exam. It was actually a two-step question. So listen to this very carefully, especially if you're sitting for the FMG exam. First impression when you look at this would be like the RR interval of the patient is reduced. I mean, most guys, when they face this MCQ, they were totally zapped because the question said or the strip showed presence of tachyarrhythmia, or rather I would say tachycardia at the moment, because I'm not sure whether it's a tachyarrhythmia or a bradyarrhythmia, but because the heart rate is fast, most students said, sir, the initial impression of mine was that this person was having a tachyarrhythmia. And it looked like even a PSVT for some people. But then one chap said, sir, in between, no, there was as if there was almost like a I would say a sinus pause. Like in this case, I have counted, I'll just zoom it in for you. There is almost nine large boxes separating the R and the R wave. So there's a sudden drop in the heart rate of this patient. If you look at this mathematically, 9 3s are 27, 33, I mean 33 to 34 beats per minute. So if you look at the heart rate of this patient, there is a combination of bradycardia and tachycardia. Guys, this is a very peculiar situation that you see in patients who are having sick sinus, in a sense that sometimes the sick sinus will not fire. So there would be bradycardia, and then it's gonna suddenly come back to life. It's not totally dead. It's not that it's not firing at all. Earlier, there was a presence of, I would say, a sinus arrest in the patient, and there was rather a sinus pause. That would be a more appropriate word, a sinus pause present. And following that, because the SC node was not firing, it is paused to fire. So AV node will become the boss of the heart. Now suddenly it is back to life again, and it will try to compensate for the lost ground or for the decreased output by increasing the heart rate. So we call it bradycardia tachycardia syndrome. Guys, this bradycardia tachycardia syndrome is primarily because of the malfunction of the SN node. The point is that SN node is not totally dead. I use the word sinus pause to simply tell that the sinus paused for a few seconds, ruk gaya. It's not firing, and then it overdoes what it was supposed to do. We told the heart beat at a constant rate. It's beating slow, and then suddenly fast, then slow, fast. So we call it bradycardia tachycardia syndrome. And guys who actually attempted the FMG paper, they were totally zapped because they had asked what is the treatment. So a lot of people thought it is a PSVT because the heart rate is 150, and they marked it as adenosine, which was present in the options also. But what's the problem of this guy? This guy is actually suffering from a bradyarrhythmia where the SA node, sometimes it is firing slower than normal, sometimes it is firing faster than normal, or it is totally shutting down. I said three possibilities: either firing lesser, or firing faster, or totally shutting down. Erratic behavior of the SA node. So for management of this patient, because there would be at a heart rate of 33 possible syncopal attacks occurring, then a pacemaker would be required in these patients. We will do a detailed Holter study, and pacemaker would be required only in symptomatic patients where there are recurrent syncopal episodes. And just sharing I would say a personal detail with you, with the permission of the doctor who was actually suffering from it. There was one of my FMG students. This girl, I mean, very brave. She actually gave me permission to actually have a chit chat with her after the exam. She cleared the exam with brilliant marks, and she was suffering from this condition. I mean, if you go to my YouTube channel and if you listen or just type this word, then you will be able to come across a video of this girl. She was actually a topper and she got very good marks, but she was diagnosed with this condition just before the exam, unfortunately, and she got this kind of a ECG in the exam per se. So a bradycardia tachycardia syndrome is something that will definitely cause problems, though luckily for her she did not require a pacemaker. But as I said, if the person is having symptomatic episodes, it would depend on the cardiologist's opinion. But as I said, I mean, if the patient is symptomatic, if there are episodes which hamper the quality of life, then pacemaker would be required. If not, then the person can be managed conservatively, in a sense that we can put the patient on a watch list, and if required, if warranted, after a couple of months, we might have these patients deteriorating into maybe a Mobitz kind of a heart block that I'll be explaining to you subsequently. So if there's a progression, then maybe a pacemaker would be required in the patient. In patients of sick sinus syndrome, the basic point is, for management of patients of sick sinus syndrome, the pacemaker would be required. Not that it is emergency to put in a pacemaker, only if the condition interferes with the quality of life, that a pacemaker would be required. Now, moving on to the next aspect that I am describing before you here, the feature that you need to pick up here is the PR interval. And the PR interval, actually the name is PR interval, but it is not from P, starting of P to starting of R. It is actually the starting of P to the starting of the Q wave. The PR interval is not till the R wave, it is from the starting of the P to the starting of the Q wave. And what is happening in this person's ECG is that the PR interval of the patient is increasing. You have noticed there is a increase in the mathematical value of the PR interval. I mean, if you just focus on the black horizontal lines that are drawn there, there's an increase in the PR interval of the patient. And then you can notice a P wave. After which I'm waiting, but there is no QRS complex. So at this point of time, the person might even put his hand on his pulse and say, sir, suddenly my pulse disappears. So I'm describing a condition where there is missed beat experienced by the person who is feeling his own pulse. Subsequently, if you look at it, the PR interval, there's a reset in the rhythm of the heart, and the PR interval of the patient will become almost identical to what it was initially. This is the PR interval that will become initially, and the subsequent tracing has been cut out, but I'll just try to draw this before you, that what's going to happen subsequently is that there's going to be a serial prolongation of the PR interval. If you compare the PR interval of this patient the first time, the second time, the third time, and then again a first time and a second time and a third time, you will notice that there would be a serial increase in the magnitude of the PR interval, and in between there's a missed beat happening. Therefore, the interpretation of mine from the first ECG is that this person is having a second degree heart block. Now, second degree heart block is of two varieties, Mobitz 1 and Mobitz 2. So please be patient while I describe Mobitz 2 to you also. But at the moment, I have demonstrated what is called as Mobitz 1 heart block. This is also called as Wenckebach phenomenon. There is a progressive, the highlight of Wenckebach is that there is a progressive increase in the PR interval, and then there's a missed beat, then again a progressive. The rhythm gets reset after every missed beat. There is a resetting of the rhythm, and most people, when I describe it, the query of them is, sir, in exam we have limited time, so I mean we will have to count the PR interval so many times, 1 2 3 4, then again 1 2 3, maybe 4 times, maybe 5 times, then there's a drop beat. It's not necessary that the drop beat will come after only 3 PR intervals also, no. So the query of most people is, sir, in the exam, because it's a pressure cooker situation, and by the time we are counting the third PR interval, we have forgotten the second one, or we have forgotten the mathematical value of the first one. So isn't there a solution to it? Well, the solution is that wherever you identify a missed beat, and to assist you in the exam, he will put up a vertical arrow for the missed beat, which is just after the P wave. Vertical height of P wave is 2.5 millimeter. What you need to do is, first of all, and listen to this carefully, first you have to look at the PR interval after the missed beat and compare this with the PR interval which is before the missed beat. If you look at the values here, now I'm just going to try and put on the values here also. If I start counting here, though it will make the image a little blurred, but still I'm trying to do this activity. This would be 1 2 3 4, approximately 5, so it's something like 200 milliseconds. But at this area, if I start counting, this is 1 2 3 4 5 6, I'm still counting 8 almost. So 8 into 40 would be 320. In fact, let me just put up the values. 320 millisecond versus 5 into 40. Every small square in the ECG is 40 milliseconds. So look at the disparity. I mean, it's 320 milliseconds versus 200 milliseconds. Upper limit or normal versus almost, I would say, more than 100% jump, or approximately about 50 to 60% jump. Mathematically I'm bad, so 200 increment 320, whatever mathematical value, but it's definitely an increase. It's not mathematically 100% increase, because 100% increase would mean 400. So, but there's a mathematical jump here. I'm not going to edit this part. I mean, I'll just keep it there, because we doctors are, honestly, I was very bad at mathematics, and that is why I took a biology and I became a doctor. So the PR interval of this patient will show a marked variation before and after. And now I would like you to be even more careful than what you are originally at this moment, and compare the PR intervals in the initial next strip that I'm doing at the moment. Even if I don't zoom in, you will, I think, agree to the fact that the PR interval, the first time, the second time, the third time, they look almost equal. Then there is a P wave, followed by waiting, missed beat again present, a vertical arrow will be present, and then again the rhythm is reset and you would be getting a PR interval, and then subsequently you would again be getting a PR interval. But the message is that the PR interval that would come subsequently will be almost of the same size. What you need to do is once again identify the missed beat. The person might again say, sir, suddenly I feel as if my heart is sinking, and I put my hand on my pulse and the pulse is disappearing. And if you look at the PR interval before and after, if you look at the PR interval before and after, then they are almost of equal size. I don't want you to compare numbers 1 and 3. I want you to compare the size of the arrows. the size of the arrow, and I did that activity before you, so I'm just going to zoom it in, which just due to the pixel issues the image tends to blur a bit, but still there is a marked variation of the PR interval before and after. In fact, the interpretation here is that the PR interval before and after will be unequal, so rather I can put it like this: unequal. Whereas inferably the PR interval before and after will be always equal. Why I'm emphasizing on this, why am I quickly zooming in and zooming out, is to sensitize you to the fact that you need to learn hacks to cut down on time. When I say hacks to cut down on the time, you just need to remember the PR interval. If it is equal before and after the missed beat, it is move bits 2 hard block. Whereas if it's gonna be unequal, then it's gonna be move bits 1 hard block. And both of these are variants of second degree hard block. Let's practice this further. At the moment, I know that the mind becomes a little overwhelmed. So let me just see if you have been able to pick up the facts here or not. And in fact, there are 3 strips which are present simultaneously. So let me just do some tracing here before you. The tracing would be like this. I'll use a different color. This is P wave, then is gonna be the QRS complex, then is the T wave. So normal sinus rhythm, so far so good. Then I'm able to identify a P wave in the patient, which I have marked with blue, but there is then a drop beat. I mean, there was no QRS complex. After which, once again, a normal sinus rhythm is coming up, the normal PQRS and the T wave are present in this patient. And then the same thing happened once again. P wave came up, there was a drop beat. Let me just finish the tracing once again. This is P, this is Q, then R, and then S. So we are once again having a normal sinus rhythm. The highlight of this particular ECG is for every one, listen to the words carefully, for every one conducted P wave, where I'm putting the markings at the moment, the one in red, I'm going to call them conducted P waves. For every one conducted P wave, there is one P wave which is not conducted downwards because there was no QRS complex that actually occurred. You see, first atria contract, then ventricle contract. So P wave is always followed by QRS complex. In this case, what is happening is that the message is that for every one P wave which is getting conducted, there's another one which is not getting conducted. So this would be technically called as 2:1 block, and this could be easily confused with Mobit's 2 hard block. How? Because the PR interval after and the PR interval before will be equal. Just before I told you, that in a person who's having movements to hard block, wherever you are gonna get a missed beat, then this is gonna be, or you will be forced to, because there's a missed beat present, you would be forced to check out the PR interval before and after, and you would get a equal value. So a lot of guys, they confuse this with Mobit's to hard block. Now the solution for this is, and I'm gonna go back to my previous slide so that you are able to understand this better, is that in Mobit's to hard block, you would be seeing, let me say, conduction, 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 then a drop, then again conduction, conduction, again a drop. So you would be having multiple conductions, multiple. What I mean by conduction is every P will be followed by a QRS complex. So there would be multiple conductions followed by a drop, then again multiple conductions. In between, intermittently, there are gonna be drops present or missed beats present. But when it comes to 2:1 block, which looks like Mobit's 2 hard block because the PR interval before and after is equal, the main issue is that for every one conducted wave, there would be one non-conducted. So we're calling it 2:1 just to highlight the ratio that for total of 2 waves, only one guy is lucky. There are 2 suitors, there are two guys who are, trying to woo the person of the opposite gender, and only one of them is lucky here. So we call it a 2:1 block. And once we have done this, which is important from the exam perspective, let's do this activity just let us simulate the exam scenario. And let me say I give you 1 minute to evaluate what is going on in the ECG, which is present currently, which is currently shown on the board. So let's do some bit of mathematics here, a bit of tracing here, so that we are able to orient ourselves better for this. This is the PR interval the first time. If you compare this with the PR interval the second time, there is a visible increase present. Then I'm gonna once again check it. It looks almost the same or slightly increased. And then what I'm noticing is that following T, this looks like a P which is just buried at the end of the T. And then this particular area that I'm marking, in fact, if I mark it, it will cause errors in interpretation. So I'm just going to use a blue arrow to highlight. This is where I anticipated a QRS complex to be present, but it really did not come. I can see a P which is buried right at the end of the T, but then this was not followed by a QRS complex in the patient. Let's take this serially. Subsequently, this is the PR interval. The heart rhythm is reset, slight increase, then again, a slight increase as compared to what was present initially. So you can see a gradual increase in the PR interval. This is what is called as Wenke back. There's a PR interval. In Mobitz 2, it was PR constant, 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 drop, constant, 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 drop. In 2:1, it was conduction, non-conduction, conduction, non-conduction occurring alternatively. In this case, there's a progressive rise of the PR interval, drop, again a progressive rise of the PR interval, again there will be a drop, and it is not necessary that the drop will occur every third beat, or it might occur every fourth beat. It could be a possibility, it could be occurring after every 5, every 6, or it could be erratic in the strip as well. The vertical arrow, if given in the exam, would usually point towards a vertical black arrow like this, would point towards, or even if he does not put a vertical black arrow, no, this looks like almost a sinus pause. So you have to evaluate what's really going on in this patient. This ECG, which is currently on the focus, would be answered by you as Mobitz 1 heart block. Or in the MCQ, instead of saying Mobitz 1 heart block, he might actually say intranodal. Why intranodal? Because the problem is inside the AV node, therefore it fails to conduct, and therefore after P there's no QRS complex. Let's look at the ECG which is given subsequently, and you can see that there is a missed beat occurring here. In fact, for missed beat, I've always used a different color, so I'll just maintain uniformity. And what I'll do now is look at the PR interval after. Always follow this rule. Look at the PR interval after and then compare it with the PR interval before. And in the exam, you won't have that pinch and zoom facility. So this time I'm not pinching, I'm not zooming in. You will have to approximate it, and you will notice that this is almost equal. So my interpretation in this case is this is Mobitz 2 heart block. So the message for you guys is that when it comes to bradyarrhythmias, they look easy to understand. I mean, there's after all only a bradycardia. I mean, most guys put it like this, so there's only a bradycardia, why so many details? But then you have to get used to the fact, that in Mobitz 1 heart block, the problem is inside the AV node. Whereas in Mobitz 2 heart block, the problem is not in the AV node, it is in the bundle of his. Damage to bundle of his is not called as bundle branch block. Bundle branch block means the damage to either the left fascicle or the right fascicle of the main central bundle of his. Bundle of his has two fascicles. No, if there's a damage to the left fascicle, we call it left bundle branch block. Right fascicle damage, we call it a right bundle branch block. But with the main bundle of his fascicle, central one is affected, that is Mobitz 2 heart block. So the message is that in the exam, when they are going to ask you heart blocks per se, you have to be prepared for all of this. And in case you have understood this well, great. Otherwise, I would suggest you to go back to this slide once again. And especially if you are sitting for an FMG exam, because there is a tendency to repeat the MCQs, I would suggest you to be very comfortable with bradycardia, tachycardia syndrome. When it comes to, let me say, INISET or a NEET PG exam, I would like you to be very comfortable with Mobitz 1 and Mobitz 2. And more importantly, 2:1 block. I mean, with respect to, I'm repeating this again, in 2:1 block, for every one conduction, there is one non-conduction. Whereas in Mobitz 2, the one strip that I'm showing at the moment, that pattern is not occurring. I mean, there's a conduction, 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 then no conduction. It might occur after multiple beats. So it's a very erratic behavior of the bundle of his that you need to get used to. Another reason why am I describing it is because the problem is in the AV node. So he will say intranodal conduction defect. Just using English and exploiting it, intranodal conduction defect. But in bundle of his, the problem is below the AV node. So the term he is gonna use for defect below the AV node is called as infranodal conduction defect. Must know aspects for you infranodal, because if you read them wrong in the exam, the chances of getting them wrong will increase. Intra versus infra is the main message, and the party is still on. So one more concept, be patient for it, which is that they're gonna give you a ECG in which the RR interval is really gonna be increased, like I can say almost 8 to 9 large squares present here. So if I divide 300 by 8 also, it still doesn't come to 40. The heart rate of the patient is still less than 40. 8 into 40 would be 320. This is about 40 beats per minute. And then what I'm noticing is that in this particular ECG recording, the number of the R waves that you are counting, the number of the R waves that you're counting is only 3. Even the QRS complex of the patient is relatively broad. Every time there's a QRS complex that's broad. So I was teaching you broad QRS complex tachycardia. Now I'm teaching you broad QRS, but there's a bradycardia occurring in the patient. And let us now count the number of the P waves. I'll just use a different color to mark the P waves here. Let's do it in a contrasting color. I'll try to use yellow here. This is one P wave. Then this is another one. This occurred. All these waves, and how am I making them to be P? Because I know the size and the duration criteria. No, I mean P wave duration is about less than 120 millisecond. That is 3 small squares. Vertical height is less than 2.5 millimeters. So I'm not calling them T waves. One that I've not marked here is just at the end of the QRS complex. That I can still say can be a T wave present. But at least if you look at this ECG, one thing that I think you would all agree to the fact is that the RR interval in the ECG decides ventricular rate, whereas the distance between the P and the P waves, this is called as PP interval, and the PP interval will be determining the atrial rate. And in you and me, the atrial rate and ventricular rate is equal. In you and me, if let me say atrial rate is 75 of yours, the ventricular rate is also going to be 75. No, I mean there's a normal sinus rhythm which is not occurring in this case. The atrial rate and the ventricular rate will not match. That is one interpretation that we have seen. Like I would say the ventricular rate of this patient is 40 beat per minute. But if I count the number of squares here, 1, 2, 3, maximum, let me say extrapolate to 4, it would still be a PP interval. That would be 300 by 4 would be still 75. So the atrial rate is 75, ventricular rate is hardly 40. The two are not matching. I'll just put the mathematical values also so that you can do some calculation here. I said, let us say mathematical value for calculation 40. And the atrial rate of the patient is coming to be approximately 75. So the atrial and the ventricular rate is not matching. I am gonna use a term here, AV dissociation. Then I also said this person is having a relatively broad QRS complex, which tells me that the pacemaker of the heart lies pretty close to the bundle of his. Every time there's a supraventricular tachycardia, there's a narrow QRS complex. If the origin is in the ventricles, there's always a broad QRS complex. Broad QRS complex is not related to tachycardia or bradycardia. Broad QRS just tells you that the origin of the problem lies in the ventricles. Heart rate is not dependent on QRS. Heart rate is dependent on the RR interval. Broad QRS complex simply means here that the problem lies somewhat in this particular person's ventricles primarily, and the number of R waves and the number of the P waves should be equal, but in this case the number is not matching. These features that I've written here before you is called as third degree heart block. And the query most people is, sir, what's really going on in this case? I mean, why is this happening? Could you explain that? So, well, I know it's a rapid revision, but I'll just try to get the concept here. The concept here is that the AV node is malfunctioning. So what is happening is the SA node is able to control the atria of the patient, and the bundle of it is able to control the ventricles. There are two pacemakers in the heart. Just like, too many cooks spoil the dish, spoil the broth. Similarly here, SA node and bundle of phase are trying to control the heart. SA node can fire between 60 to 100. Bundle of phase usually fires at around about 40. So there's a clear-cut lack of coordination in these patients, for which you will be requiring a dual chamber pacemaker. You will be sending two leads. One will shut down the SA node, other will shut down the bundle of phase. We will ask them, both of you shut up. You are causing a problem, and we will not let the pacemaker control the heart rate. So this condition that I have currently described before you, where you use a dual lead pacemaker to shut both these fellows up because they're making a mess of the situation, is what is called as third degree heart block. Third degree heart block would also be called as, it is one of the causes of AV dissociation. In fact, in some books, they might even use the term Stokes-Adams syndrome. That's mainly to describe the symptoms in these patients, that every time this person will suddenly stand up from a sitting position. His ventricular rate is only 40. When he will suddenly stand up, he might develop syncopal episodes. So people with the Stokes-Adams syndrome, they will be having severe hampering of their quality of life. Like when I was describing SC node malfunction, when I was saying sick sinus syndrome in a patient, I did not say that the person will require a pacemaker on a priority only if his lifestyle demands it. But for this case, I need to go in for a pacing. And why we use dual pacing or dual chamber pacing is because, as I said, there are two pacemakers, both are trying to control the heart, and they're making a mess of the situation in a sense that atria and ventricle are not coordinating. Atria should fill blood. What is the function of atria? Pumping blood into the ventricles. If they two will keep on fighting with each other, you could even be having those big Canon A waves in the JVP. You could be having frog waves in the JVP, and this person would be requiring a dual chamber pacemaker. Though there was an X-ray also given in the exam for a dual chamber pacemaker that I will handle here, but I'll just go back in the slides to make you revise the information here. I have taught you disease of the SA node, which is gonna be answered by you as sick sinus syndrome. Then I have taught you a disease of the AV node, which is called as Mobitz 1 heart block. Then is disease of bundle of phase, which is called as Mobitz 2 heart block. And then is complete destruction of the AV node, where you would be having two chambers. You see that, I mean, when I describe it again, the query a lot of people is, sir, you wrote AV node even for Mobitz 1, and you wrote AV node also for third degree heart block. How in the exam will we know? Well, the problem with Mobitz 1 heart block is that there is a slow conduction occurring. It's not dead. AV node is still functioning. It is a slow conduction via the AV node. But when I was describing third degree heart block, I put a line in yellow over it to say that there is no conduction via the AV node. The words are, I mean, the fundamental difference is in Mobitz 2 heart block, well, I said infranodal bundle of phase. In Mobitz 1, the problem is in the AV node, that is okay, but it is slow conduction. Whereas in third degree heart block, the word is no, N-O, no conduction occurring. So a bit of concepts here so that you are able to retain this information relatively better. And I'm done with bradyarrhythmias at the moment. We now come to summarization of findings of the ECG. And what I'll be doing here is giving a few additional points as well. Like when it comes to the duration of the P wave, this would be about 3 small squares, that is 120 millisecond. But you could be getting a P wave where the duration might be more than 120 milliseconds, and even it might be having a notch in between. Like traditionally the P wave would be having a positive amplitude, but now what I'm showing before you is a P wave which is having a notch, and at the same time I have also increased the duration. The term that we use for it is P mitral, and why would it be present is because of enlargement of the left atria, for example in a case of mitral stenosis. You see, in mitral stenosis, because the orifice is narrow, the left atria will dilate, and therefore the current will take more time to go across this dilated left atria, which results in P mitral to develop. In the same patient, subsequently, there might even be a development of pulmonary artery hypertension, when the finding that would be encountered would be called as P pulmonale. P pulmonale would mean that now there would be an increase in the vertical height of the P wave, and this would be more than 2.5 millimeters when it comes to evaluating in the limb leads of the patient. One of the important causes of this would be pulmonary artery hypertension, as I said, and why I repeated that is because in the exam they asked regarding what is pseudo P pulmonale. So as I told you, I'm going to tell you some new points, and I'm going to do some repetitions also. Pseudo pulmonale, P pulmonale would mean that the vertical height of the P wave is more than 2.5 millimeter, but this is occurring in the absence of pulmonary artery hypertension. There's no PAH in the patient, and still there is a P wave which is relatively taller. Why this would be happening is an electrolyte imbalance. Earlier I told you that hypokalemia can trigger Torsades SD pointers. Now I've just reiterated the statement that pseudo P pulmonale is to be given the same importance as you would attach to P pulmonale. The next statement to be remembered here is absent P wave, and this has been said 3 times. The first time I taught you absent P wave was atrial fibrillation, then was hyperkalemia, where the T wave will increase in amplitude, P wave will become smaller, smaller, smaller and disappear, and then would be sick sinus syndrome, which was a topic that was discussed prior to this. Then he could talk about varying amplitude of P wave, and along with this, there would also be a tachycardia component present. This varying amplitude of the P wave with a tachycardia component, and the setting would be that of a COPD patient, would be multifocal atrial tachycardia. When he says retrograde P waves, you see, P wave is always a positive wave. The only time P wave is negative is lead number AVR. Remember my words here, and because it's normal, I'm not writing it. But in the routine videos, I've described it that P wave is always a positive wave. The only lead where it is negative is AVR, and where it is biphasic is V1. But here it is written retrograde. That means the P wave is coming, I would say, instead of the positive side, the negative side. This is when the impulses which are depolarizing the atria are starting from the AV node. So they're going the other way around. You see, SA node impulses would go from top to bottom. Here the AV node is actually becoming the boss of the heart, and it is causing a retrograde activation of the atria. The condition where you have a retrograde activation of the atria, that means AV node is sending impulses upward, is called as JT, that is junctional tachycardia. All these aspects that I've described before you are to be known for the P wave, and some of them are repetitions and some of them are additional points which have been added to your vocabulary. Next, we are going to talk about two variations with respect to the PR interval. We could either be having a short PR interval or we could be having a prolonged PR interval. Short PR interval has been described for Wolff-Parkinson-White syndrome, where you also get an additional finding of delta wave with the PJ interval that is normal. And another accessory pathway that I described was called as James bundle, where we had Lown-Ganong-Levine syndrome. In both of these conditions, we are having an accessory pathway in the heart, that is AP. The accessory pathway in the heart, that is AP, will fire at a faster rate. Once it fires at a faster rate, it is going to be responsible for a shortened conduction time, and therefore I said short PR. When it comes to prolonged PR interval, this would be like a first degree heart block. First degree heart block is characterized by only a prolongation of the PR interval, and one of the reasons for this could be Ashkoff nodules which could be present between the SA node and the AV node. So the only thing that will happen here will be that the exercising capacity of the person will be reduced. First degree heart block can be physiological as well. One of the important reasons for first degree heart block is physiological. But then I said, if there is going to be Ashkoff nodules which are going to be present between the connection between the SA node and the AV node, they are going to decrease the speed of conduction. And as a result of it, well, the bad news is that there would be a prolonged PR interval, which is actually a laboratory criteria also that we use for identification of rheumatic fever, and I've described that in the Jones criteria. The number one reason for first degree heart block is always physiological. Then could be Ashkoff nodules, it could be rheumatoid nodules, sarcoidosis, they could be non-caseating granulomas that could be slowing the conduction. The next example of prolonged PR interval is Mobitz 1 heart block, but I did not write Mobitz 2 heart block because there the PR interval of the patient remains normal. Then Q waves are always written with the alphabet small q, but here we are talking about capital Q waves, that is pathological. Q waves or deep Q waves or pathological Q waves are encountered in MI, that is okay, but you can also encounter them in one of the commonest cardiomyopathies, that is hypertrophic obstructive cardiomyopathy. Once we studied regarding the abnormalities of the PR and the pathological Q waves, we are going to discuss regarding abnormalities of the QRS complex. It could be a narrow QRS tachycardia. So the word tachycardia is what I'm adding here, and the QRS word is already present. Narrow QRS tachycardia would be supraventricular tachycardia like a PSVT or atrial fibrillation or a atrial flutter. But whenever there's going to be a broad QRS tachycardia, then you have to take into consideration whether the amplitude is going to be equal or the amplitude is going to be variable. Because if it's going to be a broad QRS tachycardia and the QRS amplitude is going to be equal, I'm going to call it a monomorphic VT, where if the BP is stable, I will be using amiodarone. If it is a pulseless VT, I shall go in for a defibrillation right away. When it comes to a polymorphic VT, most of the time patients would be pulseless and would be requiring defibrillation. Otherwise, if BP is hemodynamic, the person is hemodynamically stable, blood pressure is more than 90/60, I can be using magnesium sulfate in the patient. Polymorphic ventricular tachycardia is also called as Torsades de Pointes. Then could be notching of the QRS complex. What I mean by notching is like this. In the peak of the R, The appearance that could be present could be like a rabbit ear that I've shown at the moment. That's a Q, R, and S complex. And especially if we encounter this in V5, V6, this notching or the rabbit ear appearance that I'm pointing to, this could be suggestive of bundle branch block, which could be either right or left. Left bundle branch block is always pathological and is seen with MI, but right could be physiological as well. Osborne waves is relatively easy. This would be encountered in patients of hypothermia, and the clinical setting that would be given on the question would also help you identify this. The core temperature here would be best evaluated in the lower esophagus, as I have explained earlier. However, we can be having a delta wave, so I'm gonna hand draw this before you. Delta wave would mean, in fact, I can use a different color to highlight this. Once the P wave is finishing, in the upswing of the R wave, there's going to be change in the slope, like the one that I have shown at the moment. This that I've shown is the delta wave, and this would be encountered in patients of Wolff, Parkinson, White syndrome. In contrast, when it comes to the epsilon wave, it can look notoriously almost the same as the Osborne wave. And well, let me just sketch it, and then I'll be able to do justice to this relatively better. This wave that I have currently shown at the end, you see, Osborne wave also occurs at almost the same time. That is where I've shown the epsilon wave. But this epsilon wave, if asked to you in theory, you should be spot on in your answer, because this would be cardiomyopathy by the name of ARVD and can contribute to sudden cardiac death. So we not only have SCD or sudden cardiac death in hypertrophic cardiomyopathy, but we could be having it even in arrhythmogenic right ventricular dysplasia. The disease would be having problem with respect to fibrofatty deposition in the or just below the endocardium, or I would say more towards the pericardium. So there's a fat and there's fibrous material where there should be muscle. No, I mean, between the endocardium and the pericardium there should be muscle, but here this muscle is being replaced by fibrofatty material, and that is a recipe for disaster, because if you have abnormal tissue in the heart, there could be automatic I would say automaticity that could be enhanced in some muscle areas, and that enhanced automaticity could result in ventricular tachycardia or even a polymorphic ventricular tachycardia, which could explain the sudden cardiac death in these patients. One way to differentiate would be, obviously, I mean, if the ECG is in the ECG you are finding a wave like this, and you are not sure that this is ARVD or this is going to be hypothermia, clinical scenarios would help you, because for epsilon wave, the only history available would be that my elder brother or sister died suddenly. But in hypothermia, there will be settings for hypothermia. No, it could be myxedema, coma, or a soldier, brought down from Siachen Glacier to the base hospital in Chandigarh and maybe subsequently to Delhi, and the clinical settings would help you identify it. Moving ahead, we have ST segment elevation, very characteristic. So let's look at this mnemonic elevation AB to remember the causes. The first alphabet E here will be for electrolytes. And the electrolyte that we are talking about here would be hyperkalemia. I mean, in hyperkalemia, there is a tall tented T wave. When T goes up, ST would also go up simultaneously. Alphabet L would stand for left bundle branch block. Point number 3 is very harmless. This could be present in you and me also. We call it early repolarization variant. So some people could be having ST elevation in their ECG in few leads. It will not follow a pattern, like in MI, there's V1 to V4 or lead 2, 3 AVF. It's not going to follow a pattern. So this is called as early repolarization variant. Then alphabet V and A are to be taken simultaneously. This condition that I'm writing right now is a complication of MI. You see, if somebody has anterval MI or there's an extensive anterval MI, there would be structural damage to the heart. This structural damage to the heart would result in ventricular aneurysm, and this could trigger a ventricular tachycardia. Alphabet T here would stand for trauma. This trauma could be maybe a road traffic accident, or they could be punched to the chest, which could be contributing. Or I can say that even if pericardiocentesis is being done, there's a possibility that your guide wire or your needle that could be introduced could be touching the surface of the heart. So pericardiocentesis as a procedure, though it's very safe nowadays, it's echocardiographic guided, but in earlier times when we were using or we were not having those pigtail catheters available, there's a possibility that the procedure itself could traumatize the heart and it could cause a ST elevation because there's a muscle damage present. Then would be ischemia. This is anyway understandable. Myocardial infarction, where we have discussed regarding a person would be having ST elevation convex in upward direction called as Pardy sign. Alphabet O would stand for Osborn wave. That's hypothermia setting, because Osborn wave also occurs right at the J point. I'll just reiterate that once again. This is what I've told you. The end of the S is called as the J point. And in a soldier with hypothermia, you might be getting a ECG like this, where the P wave might be smaller, SA node is not firing due to hypothermia, the PR interval might be substantially, I've super exaggerated it. In fact, there would be a broad QRS complex because everything is slow, and then you might be getting a abnormal wave here that I'm gonna show, and this is different from the T wave that has been shown subsequently. It may not be so big as I've made it out to be, but in a setting of hypothermia, this is easily picked up. Then alphabet N is actually parenchymal angina, but just to fit it into the discussion here, alphabet N would stand for non-occlusive vasospasm. I described that all anginas would be having ST depression. The only angina having a ST elevation would be parenchymal angina. I'm using a short form for it, that is PA. Then alphabet A would stand for acute pericarditis. Right in the starting of this video of cardiovascular system, I told you that ST elevation, if it is concave upwards, present in majority of leads, that would be pericarditis, along with the clinical history, pericardial friction rub, that will make it easier for you. And alphabet B would stand for Brugada. Now, as far as Brugada is concerned, this is of special interest to the examiner because this is a sodium channel defect. Just like we have channelopathies in neurology, we could be having channel defects in the heart. This is SCN5A defect. And in this patient, again, sudden cardiac death could be occurring. And the ST elevation of this patient is very peculiar in a sense that if you focus on the ST elevation that I've shown here, followed by a T wave inversion, this ST elevation with the T wave inversion, this is called as Cove pattern, COVE. The Cove pattern as a term implies the changes that I have highlighted here before you. So at the moment, ST segment elevation, elevation AB is the mnemonic, and it will take a while for you to get used to all these terms, but then once you remember the mnemonic and the implications related to it, you would be able to pick it up. For MI, I can still draw it. This was convex in upward direction with the T wave inversion. This would be for MI. And for pericarditis, it's gonna be concave in upward direction. As you can see the difference here. The one with the star mark is for MI, and the one which I've not written anything but concave upwards is for acute pericarditis, which could be usually a viral pericarditis or maybe even a post COVID-19 pericarditis, or even a combination of myocarditis and pericarditis can be seen post COVID. ST segment elevation is a must know information that you should be remembering. Now we're going to talk about conditions where we have ST segment depression. The first time I ever spoke about it was unstable angina, then is non-ST elevation MI, and then is electrolyte imbalance, hypokalemia. In hyperkalemia, arrow is going up, so T wave is also going up, ST is also going up. In hypokalemia, we would be having a T wave inversion present. In fact, the causes of I would say T wave inversion would be identical: unstable angina, MI. Now here I have not written non-ST elevation MI. I've just written MI because both varieties of MI, ST and non-ST elevation MI, can be having a T wave inversion, and hypokalemia. Thankfully, it's somewhere the data is getting repeated. Hyperacute T waves is anyway MI, that is ST elevation MI predominantly. Tall tented T waves is hyperkalemia. So this particular part I think still can be easily remembered. And now I'll introduce a drug here which is to be remembered also with the same aggression as you are remembering the remaining informations, that is digoxin. I did not say digoxin toxicity. Digoxin toxicity will result in a tachyarrhythmia. In fact, this is itself a question. Digoxin toxicity can trigger which rhythm disorder? It is ventricular bigeminy, which will be alternative normal sinus rhythm and premature ventricular contractions. Here I just said that digoxin itself can cause a ST depression. That explains the reason why, like if somebody is going to be subjected to treadmill test, we would be discontinuing digoxin before we do a treadmill test in the person if it requires so, because otherwise it could be drug that could be causing ST segment depression. Next on the agenda is prominent U waves, relatively easy to remember. Hypokalemia, which is coming up again and again. And then is QT interval. QT shows the inverse relation with calcium as well as magnesium. And most of the time, the questions would be like, when they talk about tetany, he would talk about Chaustuck sign, Trossard sign, and then also incorporate that there's a QT prolongation. The word is tetany will be having a QT prolongation, vice versa, but that QT prolongation is important because lots of time there might be written as QT prolongation, but below the word QT there might be a small subscript C. Well, this small subscript C stands for corrected. Let's understand what this QTC means in contrast to plain QT. This QTC means QT divided by root of the RR interval. I mean, this is a mathematical formula which can be asked by itself. What is QTC? It's QTC with the C alphabet stands for corrected. And this is one of the diagnostic criteria for polymorphic ventricular tachycardia, which was also known as Torsades de Pointes. Magnesium sulfate was the drug used, otherwise in hemodynamically unstable patient we were anyway going in for defibrillation. Then we come towards a term which is usually taught in respiratory system, but I thought I'll talk about it here also. The findings present here are deep S in lead number 1. In fact, why this is, I can say why examiner can ask you this is because of the fact that the name is like that, no, S1, Q3, T3. So there would be deep S in lead 1. Then it would be deep Q waves in lead 3. And it would be inverted T waves with respect to lead number 3 again. And where would you be getting it? The answer would be a patient having a massive pulmonary embolism. Like this gentleman, he had a deep vein thrombosis. There was thrombus in the soleal vein which went retrogradely, and this has retrogradely gone, and it has caused a physical obstruction. That physical obstruction that has occurred is in the pulmonary artery bifurcation or in the main pulmonary artery trunk, which could cause problems for the patient in a sense that there would be pulmonary oligemia, breathing difficulties, and even chest pain, and the right ventricle of the patient will fail. Massive pulmonary embolism is discussed separately in the respiratory section component, but this that I've discussed before you, the couple of slides which I can just go back, and I would suggest you to write down this information. I mean, I know that you have printed notes, but then, or you have PDF in the app, but then all this information that I have jotted down before you, it's highly advisable that you go through it. Then came a very, I would say, striking question, and I was zapped because this was asked in the FMG exam. The student mind said, sir, there was an X-ray which was showing a device in the chest, so we thought it must be a pacemaker, but they had asked regarding the leads. One, you can see there are two leads, so I'll just mark that initially. One of the leads is curling up like this, where the right atria is supposed to be present. Another one is going to be curling like this towards the base of the heart. This is actually X-ray, which is surprising because I thought that he will ask theory, and he just shocked everybody by actually asking you regarding this pacemaker, which will be sending two wires, one, or if this is a dual chamber pacemaker or dual lead pacemaker, which is controlling the right atria and the right ventricle. The question said, where is the lead located? So I mentioned the anatomical areas. I mean, he can put arrows at any of the two areas per se, but this chest X-ray shows a dual chamber pacemaker. We also have a triple chamber pacemaker where one of the leads would be then going on towards the left side of the heart. That would be mainly located in the coronary sinus. So, but you would be able to pick it up because there would be a separate lead that would be positioned the way I have done at the moment. But in this case, you can see only two leads, one in the RA, one in the RV. So this is a dual chamber pacemaker, and this I was teaching you would be useful for complete heart block where you have AV dissociation and is also called as Stokes-Adams syndrome. Coming to the next topic, congestive heart failure. One, I can say if there is acute pulmonary edema in a patient due to congestive heart failure, then we shall be using the following drugs. The mnemonic for that would be LMNOP. In fact, in Harrison, normally he mentions only text, no mnemonics, but this is one where he has been kind enough, benevolent to us to actually mention the mnemonic here. Alphabet L would be for Lasix furosemide. Morphine, why are we giving it here, is not for chest pain because morphine also reduces pulmonary edema. N would be for nitrates, which will reduce the preload and the afterload. We shall be using oxygen in the patient, and then positioning in a sense that the person should not be made to lie down because that will cause orthopnea. So the person will be rather propped up. The patient would be in a sitting position. This that I mentioned before you, LMNOP is acute pulmonary edema, and a lot of these patients could actually progress subsequently into chronic congestive heart failure as well. So let's look at the drugs, how efficacious they are with respect to chronic heart failure, and this is a table from Harrison. In chronic congestive heart failure, we shall be using mainly A and B, as you know, ACE inhibitors and beta blockers. Beta blockers, why? Because they will reduce the heart rate of the patient, and we don't use every beta blocker, but we'll be using ones like metoprolol, the time-tested one, or carvedilol or bisoprolol. So it is A plus B that will be, I mean, you can see, the way the curve is. I mean, the first answer would be A, then would be B, and then we will also be using aldosterone antagonist. The aldosterone antagonist that is talking about here is spironolactone. The advantage would be that this will help in mobilizing the pedal edema component. A lot of these patients would be having weight gain. So a combination of A, B and aldosterone antagonist would be useful. Then is also mentioned that instead of A plus B, you could also be using ARNI. ARNI would mean that is use of sacubitril and valsartan. The logic behind usage of sacubitril is that it will potentiate the effect of BNP, that is B-type natriuretic peptide. It will cause natriuresis, and if you have natriuresis, you have salt loss from the body. Along with salt, there would be water loss from the body also, so that will help the patient in fact. So when it comes to ARNI, it's gonna be valsartan and sacubitril that would be used here. Then another welcome addition is SGLT2 inhibitors. SGLT2 inhibitors would be like emflaziflozin or canagliflozin. So SGLT2 inhibitors are used in cardiology. A lot of these patients could be having concomitant diabetes mellitus. So SGLT2 inhibitors have also been shown to reduce mortality along with drugs like vericiguat or omecamtiv. Now, as far as the usage of these drugs is concerned, you very well can see the advantage of using the traditional drugs. Why? Not that they are old, but they have described regarding the ones which would be having a reduction in the mortality of the patient. Then they have also divided the discussion into heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So I would just like to say the word preserved ejection fraction is a misnomer, because this looks like as if the ejection fraction is normal, which is not the case. For patients who are having heart failure with preserved ejection fraction, preserved here means that the ejection fraction would be in excess of 50%. Then you will read about heart failure with reduced ejection fraction, where the value would be less than 40%. And as far as mortality in these patients are concerned, obviously, if there's a heart failure, there could be cardiorenal syndrome, there could be decreased blood supply to kidney, vital organs will be affected. But at the same time, there could be non-cardiac causes also, which could contribute to mortality. As far as the death rate is concerned, non-cardiac causes, mortality in both of them is equal. You see, the word is reduced ejection fraction. So obviously, if somebody is having low ejection fraction, death rates will be higher. I mean, these people, 60% of these patients could be dead by 5 years. 60% of these patients with heart failure could be dead in the next 5 years. That's the impact. I mean, heart is a vital organ, the pumping organ function is affected, but as said, non-cardiac mortality has been found to be equal. Now, what are the strategies that he has mentioned, especially for heart failure with preserved ejection fraction? He has one talked about ARNI, sacubitril valsartan, that I was talking about earlier, and also under investigation is SGLT2 inhibitors. So I mean, they are one of the very welcome anti-diabetic drugs that have been shown to reduce. This is itself a question. I mean, which anti-diabetic drug is reducing cardiovascular mortality? It would be drugs like canagliflozin, etc., which are SGLT2 inhibitors. SGLT2 is present in the proximal converted tubule of the kidney. And how does it act? I mean, if you use SGLT2 inhibitor, it promotes urinary loss of sugar, and therefore the blood sugar values of the patient would be coming down. Once I've described the important drugs there, LMNOP, A plus B are the main agendas which are to be remembered, along with obviously for heart failure with reduced ejection fraction. Once they go into the chronic format, then along with A plus B, instead of A plus B, we can be using ARNI in the patient also. So next I'll be describing a question here before you that has been asked for the topic of heart failure, and the question said which of the following is wrong about heart failure. The option A said non-cardiovascular mortality in heart failure with reduced ejection fraction is 40% and non-cardiovascular mortality in heart failure with preserved ejection fraction is 15%. I told you that the mortality from the non-cardiovascular causes has been shown to be equal. So this particular statement is straight away a wrong one. Let's look at the remaining options. Death rate is fairly high in heart failure, understandable. Non-rheumatic atrial fibrillation results in embolic stroke. You see, I could not place option number C correctly with the heart failure topic. I mean, probably what you tried to imply, because sometimes wrong recalls can also have a biases, that the question could have been that in a person with structural damage to the heart, there could be atrial fibrillation, the clots in the heart can then go to the brain and there could be embolic stroke. So C, I would say, is not directly related to heart failure topic, but then probably, as I implied, that this could have been an association between structural damage and atrial fibrillation and stroke. D statement, I mean, nobody had an issue with that. ACE inhibitors, which are used in chronic congestive heart failure, could be having angioedema in 1% cases and dry cough in 10 to 15%. So the answer is pretty obvious for this one. And as far as the topic of heart failure is concerned, I would also suggest you to read about it from pharmacology, the drugs which are taught, and that would give you more leverage to solve questions related to this topic. One of the important causes for why heart failure could be occurring is myocarditis. And diagnosing myocarditis, which causes heart failure, is always a challenge. I am giving you reference here of page 1960 of the latest edition of Harrison, that is Harrison 21st. And what I say will look or will appear slightly controversial to you, because the radiologist would tell you that the best way to diagnose a myocarditis case would be a cardiac MRI. Absolutely. I mean, I do not dispute that. Yes, nowadays we would like to go in for imaging, and by imaging, we will be able to identify the changes in the contractility of the heart, or there could be like a late contrast enhancement occurring. So, from the radiological perspective, what the criteria that are present from the radiological perspective, and I'm just zooming it in, are called as Lake-Lewis criteria. But when it comes to pathological identification of myocarditis, there are certain criteria which you need to remember. So the names are important. First of all, Dallas criteria is histopathological criteria for diagnosis of myocarditis, and Lake Lewis criteria are for cardiac MRI. They might write like CMR. Once you get the names right, then the boon of contention or the controversy is that I would be saying that the best way for diagnosis of myocarditis is endomyocardial biopsy. This is what Harrison says, that definitive, that's the word, definitive myocarditis is diagnosed when there is either a histological or a immunohistological evidence of inflammation on endomyocardial biopsy. Honestly, I do not fancy invasive techniques. It's not that from a clinician's perspective that I'm saying, or from a radiologist perspective I'm saying. I said I have given you the page number of the textbook, which is widely used as a standard reference book. So in the exam, they did put up this question: what is the best way for identification of myocarditis? You will say, see the radiologist saying the word cardiac MRI. I don't dispute that. Yes, that is also given in Harrison, that with cardiac MRI you can be able to pick up myocarditis. And he also says the fact that I mean, though the findings are not specific, he said this word that the findings are not specific, but then there are certain criteria that help you identify myocarditis. Overall, tissue diagnosis would always matter. Cardiac MRI may not be able to provide you with a tissue diagnosis. So I would suggest that if this question is asked, if he says both of them, like they ask in any set, actually this is a any set question. So if you are appearing for FMG exam, don't get bothered by the controversy that I'm raking up here before you. Just get the names right, Dallas criteria, Lake Lewis criteria, and you're done. Especially for any set perspective, remember endomyocardial biopsy, reference is that of Harrison, would be relatively superior a choice as compared to, I would say, a cardiac MRI for the topic of myocarditis. This would be an important cause of heart failure. And well, why would myocarditis occur? It could be due to parvovirus. Earlier, we used to study primarily Coxsackie B as a cause of myocarditis, but now we study parvovirus, and then obviously, you know, COVID-19, especially Delta strain. We did not see that myocarditis coming up with the Omicron strain, but COVID-19, the Delta strain, we did come across cases which were having myocarditis, and in pediatric cases we were not getting myocarditis, but we were calling, I mean, we were not using the word myocarditis, we were calling it MIS-C, multiple inflammatory syndrome seen in children with COVID-19. These are two important causes of myocarditis that should be remembered. Apart from rheumatic fever, Ashkoff nodules could be affecting the endocardium, but then rheumatic etiology could be also causing congestive heart failure occurring in a child. Now, once we get these causes right, then we talk about diseases of the pericardium. So I'm moving to the outside of the heart. And in disease of the pericardium, my first objective would be to talk about cardiac tamponade. Now, I'll zoom into these two images. The first one that I've shown, the amount of fluid outside the heart is relatively lesser. Normal fluid, how much fluid is present normally outside the heart? So normal amount of fluid outside the heart would be in the range of about 20 to 50 ml pericardial fluid, which would be for lubrication. But once the fluid goes beyond this, then I'm going to call it pericardial effusion. So let me say the amount of fluid has increased from 50 to 75, maybe to 100 ml. So it will definitely start putting pressure on the heart from outside. But at the moment, the pressure on the heart from outside by this pericardial effusion. In fact, let me just call it a massive pericardial effusion at the moment, but still the pressure on the heart is very limited. So filling of blood in the ventricles is still occurring. However, in the inferior diagram, you can see that the amount of fluid has also increased, and this fluid has increased in a short period of time. If it takes longer period of time, the heart will be able to adjust. But in a short period of time, let me say over a few minutes or hours or days, I said quite variable in the definition. It could be minutes, like, car accident. It could be hours, or it could be days. Then the pressure will increase dramatically. It will press on the heart from outside, and the input into the ventricles would be lesser, and the output would also be hampered. So what I've tried to do in this diagram is create two situations for you. Situation number one that I am writing here would be called as low pressure cardiac tamponade. Low pressure cardiac tamponade. I mean, on one hand I'm saying the word tamponade, and the second hand I'm saying the word low pressure. So query of most people is, both the words really don't make any sense. I mean, cardiac tamponade means pressure on the heart from outside. On the other hand, you're saying low pressure. So what I'm trying to say here is that in these patients, the pulse would still be appreciated. I mean, the pulse of the patient can be weak because there is pressure on the heart from outside. So less blood can come in, and therefore the pulse may be weak. But if you look at the inferior diagram, there I'm not using the word high pressure cardiac tamponade because there's no term like this. Only I'm using the word cardiac tamponade. But when I say cardiac tamponade, it is to be taken in the sense of high pressure cardiac tamponade, that the pressure is so much that the input into the heart would be lesser. If I say input into the heart is lesser, it would cause obstructive shock. If there is hardly any blood coming in the ventricles, then the output will also be affected, and the pulse of the patient might actually become so weak that the pulse might also disappear. Now, the surprising thing is, I'm not teaching you that there's a cardiac arrest. Heart is still beating. Heart is beating, but the pulse of the patient is disappearing. So what I'm pointing at the moment is to the presence of pulsus paradoxus. I wanted to tell you that pulsus paradoxus as a feature is seen with cardiac tamponade, but the same pulsus paradoxus would be answered by you as absent in a patient who is having low pressure cardiac tamponade, and that's the term which is to be remembered. Low pressure cardiac tamponade, the input in the heart is still present for you to be able to appreciate the pulse. The pulse will be feeble, pulse will be weak, but at least it will not disappear. In cardiac tamponade, the pulse tends to disappear in the phase of inspiration. So alphabet I here means that it is inspiratory disappearance of the pulse. But the message that I'm giving you here is that pulsus paradoxus, whenever you are checking, one, you will ask the patient to do normal breathing. Like the question said, during pulsus paradoxus evaluation, would you ask the patient to take a deep breath, hold it there, exhale out hard, and then hold your breath? I mean, it was deep inspiration, hold your breath. It was deep expiration, hold your breath. It's going to be normal breathing by the patient, whereas we are going to check out the systolic blood pressure of the patient in the phase of inspiration and expiration. And shockingly, in inspiration, I'm not saying deep inspiration, in routine inspiration, the BP will disappear, or BP will become so less that the pulse you might actually appreciate is disappearing. So pulsus paradoxus is specifically a finding that is seen with patients of cardiac tamponade, though it can be seen even in pregnancy, no big deal about it. From pregnancy that the gravid uterus is pressing on the IVC, so the venous return to the heart is less. If input is less, output would be less. But especially for cardiac tamponade, because there are multiple questions, so you should be clear about it. And two important causes of cardiac tamponade must know is always, a guy driving a car without a seat belt. If he rear ends a truck from behind and there's no seat belt, the chest will slam into the steering wheel and that will cause a cardiac tamponade. Or for that matter of fact, it could be a patient of tuberculosis who's not taken treatment. So there's a massive pericardial effusion, then a low pressure cardiac tamponade, and then cardiac tamponade. Sequence dekhiye. Massive pericardial effusion, then there could be a low pressure cardiac tamponade, then not officially a high pressure, but yes, that is what I imply here, that there would be obstructive shock occurring in the patient. And if cardiac tamponade occurs, the BP of the person will begin to crash. So the only way to get rid of the problem here would be to go in for urgent echocardiographic guided pericardiocentesis, and he will say what is the site where you would be putting in the needle to remove the fluid. Obviously you'll put in a guide wire, subsequently a pigtail catheter, and the fluid will come out. But this echocardiographic pericardiocentesis, the approach that you will be using in this case, would be a Ziffy-Sternal approach. So first and the foremost, you need to remember regarding the aspects that I have just said here before you. And to give you a summary of the disease of the outside of the heart, for pericarditis, what they'll usually love to ask you would be the ST segment elevation that would be occurring in the ECG. It would be concave in upward direction. If he wants to make it sound a little sophisticated, instead of saying ST elevation concave upwards, he might actually say PR segment. I have never used this term earlier before. You have always used the word PR interval. This is the first time that I'm using the word PR segment. So he might say the word PR segment depression. When it comes to pericardial effusion, the finding that would be usually given of the ECG in the MCQ would be electrical alternance. I have shown you a ECG of this one where there's a variation in the amplitude of the QRS complex, but there's no tachycardia happening. Like it was not a variation in the amplitude of the QRS complex with respect to like a polymorphic ventricular tachycardia. It was just that it was normal sinus rhythm. I'll try to sketch it before you. Because of pericardial effusion, one thing will also happen is low voltage complexes would be coming, low voltage ECG. So what I have done here is, just be patient while I sketch it before you. What I've done is the height of the QRS complex, the duration of the QRS complex is normal, but the height of the QRS complex is varying in this case. This is mainly a feature that is seen with pericardial effusion, where there's fluid accumulation outside the heart, and the reasons could be ranging from tuberculosis to malignancy to even uremic, the person having kidney failure, and then there could be uremic pericarditis followed by uremic pericardial effusion as well. When it comes to cardiac tamponade, electrical alternance will still be present. The electrical alternance severity will increase. The point is, in cardiac tamponade, which is one step above pericardial effusion, the electrical alternance component will increase as compared to normal. So I put a plus sign in front of it. But the additional feature that would come up for cardiac tamponade is presence of pulsus paradoxus, which would not be present in pericardial effusion. As I told you the sequence, you have a pericardial effusion, then it becomes massive, then you have a low pressure cardiac tamponade, and then you have is a cardiac tamponade developing in a patient. So this is the time when there would be a inspiratory disappearance of the pulse. I here means inspiratory disappearance of the pulse of the patient. When it comes to constrictive pericarditis, you will easily pick up the MCQ because here ECG finding of electrical alternance would not be given. Why would it not be given? Because in these patients, there is going to be calcification outside the heart. There's no water outside the heart. You see, in both pericardial effusion and cardiac tamponade, there is fluid outside the heart and the heart is dancing in that bag of fluid. Heart is dancing in that bag of fluid. So you get electrical alternance. It's because of fluid. But in constrictive pericarditis, there is a calcification. So this calcification will limit the voltage. So you would be getting a low voltage ECG. I use the word low voltage ECG even in pericardial effusion. I used the word low voltage ECG even in a case of pericardial effusion, but the reason was different. It was fluid and here it is a calcification. Now there is a possibility that in the question pulsus paradoxus could be described even in case of constrictive pericarditis. But then what are you gonna encounter in the question? that would help you pick up that this is constrictive pericarditis or is it cardiac tamponade, is what I tell you next. This word is a must know for you because he might use this term multiple times. This is a auscultatory finding that is called as pericardial shudder. The blood comes in the heart, it tries to dilate the calcified ventricle and the blood will fail to dilate that calcified ventricle. So the blood will strike the muscle, bounce off. Why that blood bounces off? In you and me, the blood comes in the heart. Our heart is compliant. It is able to dilate. Here it is a non-compliant heart. So the non-compliant heart results in auscultatory finding because blood hits the muscle, bounces off. We call it pericardial shudder. Instead of pericardial shudder, there might even be mention of the word pericardial knock, or they might be mention of the term pericardial shock. Pericardial shudder, pericardial knock, pericardial, I mean all these terms basically mean the same and they are very specific findings for constrictive pericarditis. And suppose it does not give you this auscultatory finding, then he will always talk about the rise of the JVP on inspiration. In you and me, JVP always falls on inspiration. Normal person, you take a deep breath, hold it there, JVP column will fall, but in these patients there is ulta, there is opposite, so you call it paradoxical rise of the JVP, that is Kussmaul sign. So these findings that I mentioned here before you, if given with pulsus paradoxus, low voltage ECG, and the reason why I have changed the ink here is to mainly sensitize you to the keywords because the questions could be really longish. Constrictive pericarditis is usually seen after cases where a person had tubercular pericarditis. ATT was given for 6 months. But still, there could be calcification developing around the heart that can be picked up either by a cardiac MRI or at least a CT chest. CT is very good for calcification. No? So if I don't have a cardiac MRI facility, I can do a CT chest in the patient. Another feature that should be remembered, must know table for you guys if you need to get the questions right. And over and above this, I want you to remember that Kussmaul sign would be seen in the following conditions. The mnemonic is CRR. It would be constrictive pericarditis, restrictive cardiomyopathy, and right-sided heart failure. How can he write right-sided heart failure? That is on him. He could describe inferior wall MI. Right-sided heart failure is seen in pulmonary embolism. It is seen in COPD, or he might write the word cor pulmonale. Whatever be the situation, if the right ventricle will dilate, there would be no space in the right ventricle. When you take a deep breath in you and me column falls, that means blood can go towards the heart and our heart can accommodate. But a failing heart cannot be expected to dilate and accommodate the blood. So the column is not going to fall, rather it's going to rise because there's no space in the heart. In restrictive cardiomyopathy, the problem is that of fibrosis in the heart, stiff heart. Constrictive pericarditis, again there is a stiff heart. So for point number 1 that I wrote, C, constrictive pericarditis, it is stiff heart due to calcification. In restrictive cardiomyopathy, as I said, there is a stiff heart. Why? Because there is fibrosis in the myocardium. And right-sided heart failure, well, there is no space present. So Kussmaul sign is encountered in following situations, but is not seen in cardiac tamponade. In cardiac tamponade, we have a non-pulsatile elevated JVP. Guys, in cardiac tamponade, the JVP pulsations disappear. You see, what I said was Kussmaul sign there should be a rise, तो दिखना चाहिए ना कि भी rise हो रहा है. जबकि cardiac tamponade में pressure इतना ज़्यादा बढ़ जाता है that the column does not fluctuate. The column becomes totally stable, or I would say non-pulsatile. So that's again a diagnostic criteria for identifying a patient who's suffering from cardiac tamponade. So I'll come back to this X-ray in a while, but I would just like to state Beck's triad here. You all are aware of this from surgery, but just look at the inputs that I provided to you. The first component in this patient would be hypotension. That was because input in the heart was less, output would be less. So obstructive shock is coming in, pretty understandable. Then would be the word muffled heart sounds, or he might say the word distant heart sounds because there's fluid outside the heart. There might be blood outside the heart. So that is why muffled. But the third feature is important. He will casually write the word congested neck veins. That's understandable. Pressure on the heart from outside will contribute to congested neck veins to occur in the patient. But the big but here is that once you are having a congested neck veins, the pulsations of the JVP in this particular case will disappear. It would be, or rather I can write it a better way. I can write it non-pulsatile. It is non-pulsatile elevated JVP. In all conditions of cardiology, you will always be having a pulsatile elevated JVP. I repeat my statement. In all conditions of cardiology, you always have a pulsatile elevated JVP, but the only time you're gonna read this particular phrase, non-pulsatile elevated JVP, is gonna be cardiac tamponade. In fact, this non-pulsatile thing could also be described as follows. He might write terms like steep X descent. You know about the waves in the JVP. So he will say steep X and absent Y descent. That absent Y descent means filling in the heart is not occurring. The word non-pulsatile elevated JVP could be written as point number 5. Both basically mean the same. In backstride, there are three things: hypertension, muffled heart sounds. 1 and 2 will never have a problem. It's the third one, especially non-pulsatile aspect, which is to be understood. And apart from this, you would also be having pulsus paradoxus. Pulsus paradoxus is not a component of the backstride. Pulsus paradoxus, which is not found in low pressure cardiac tamponade, is a diagnostic feature of cardiac tamponade, which we are taking as high pressure cardiac tamponade. Backstride does not include pulsus paradoxus. Most of the MCQs with respect to cardiac tamponade will incorporate the data that are put up in green, because remaining things are easy. I mean, nobody will mess up a MCQ in cardiac tamponade with respect to backstride. It is mainly point number 3, the non-pulsatile aspect, and 4, 5, 6, which are to be remembered. And 6, though it's a repetition, it was important for me to say that the query of most people is there is pressure on the heart, so there should be elevated JVP and it should rise. But here there is no pulsation, no. For Kussmaul sign to be appreciated, I said Kussmaul sign is paradoxical rise. If there are no pulsations, I can't say whether it is rising or whether it is falling. So I am writing here Kussmaul sign is absent. Point number 4, 5, 6, I would say, need the respect that they deserve from the question's perspective. And most of the time, the scenario given to you for cardiac tamponade will either be a car accident, guy not using a seat belt, and the chest slams into the steering wheel, or it could be malignancy. It could be malignant pericardial effusion due to either breast cancer or lung cancer that has metastasized to the heart of this patient. So, especially diseases of the outside of the heart, I would like you to remember. And then they have given an X-ray also, which is called as a water bottle appearance, which is easy to pick up, or is also called as a money bag appearance. Coming to the subsequent topic, I'll be explaining to you the various types of cardiomyopathies that we encounter in clinical practice. You see, in Robbins it is given that the commonest type of cardiomyopathy is the dilated subtype. But once we talk about clinical textbooks like Harrison, he mentions that the commonest variety is hypertrophic cardiomyopathy. In fact, he has also mentioned the incidence of hypertrophic cardiomyopathy being as high as 1 for every 500 people that you would be meeting. So considering that high incidence, I would suggest you to answer hypertrophic as the commonest one. And then there is a subtype of HCM that we call as HOCM, that is hypertrophic obstructive cardiomyopathy. Well, there are multiple genes that are involved, but the one that they'll always ask you is the commonest gene involved for development of this condition, which happens to be autosomal dominant, that is MYH7 gene, and this would be encoding for beta myosin. Now, there's a line diagram for the obstructive cardiomyopathy component that you can see on the slide in the upper right hand corner. But before I get to that, I'll just cater to the routine question that comes on this topic. That is that we are talking about a young guy, is let me say about 15 to 20 years of age, and normally he is not very athletic, and routinely he is not able to participate in sports. Usually his friends make fun of him because he is not able to run as fast as them, or he is not able to match their physical stamina. So this guy gets breathless very soon, or this guy gets tired very soon. He is not able to match to the physical stamina of other boys who are, let me say, 15, 16, 17, 18 years of age. And today in his colony there was a football match, and his colony team was short on one guy. So his friends told him that today is your lucky day, you get to be on the football team. And this guy's super excited that, today I'm gonna play a football match, and normally with the same friends who normally ridicule him. So maybe he even told his mom or dad that I'm gonna be playing football match in the colony, and his mom or dad might have even come with a small handy cam or with a camera or with a mobile phone, and they might be making a video of him. Now this guy is playing football and he's trying to run as fast as his friends, and unfortunately during the match he collapsed, and maybe the player adjacent to him thought that he had fallen accidentally. He did not get up for 1 minute, 2 minutes. So the guy who was closest to him ran up to him and said, "Buddy, get up, get up. The match is still continuing." And this guy did not show any movement. And when he touched him, he found that he actually, his lips were blue, and maybe even CPR was given for this guy, but unfortunately he had expired. So lots of time you read about this question that I just described: sudden death in a football match, or sudden death in a basketball match, or a guy who's accepting a challenge in the gym and is trying to do bench press of twice his body weight. So though you have done these questions lots of times, sudden death in a football match, etc., my query to you guys today would be that what really happened? I mean, why did he die suddenly? Then you very well know that in hypertrophic cardiomyopathy, because you are having asymmetrical septal hypertrophy, you have a lot of hypertrophy, useless muscle in the free wall of the heart, as a result of which the oxygen demand of the heart is more. So when this guy will try to run faster, it will trigger a ischemic ventricular fibrillation, and in the absence of a defibrillator, which will usually be not available in most of football matches, at least in India, this guy is not going to make it to the hospital and would usually become brain dead in the first 4 minutes. And by the time he's brought to the hospital, I mean, the person would be pulseless and BP-less. So ischemic ventricular fibrillation should be answered by you as the reason for development of sudden death in a patient of hypertrophic cardiomyopathy, where the oxygen demand of the heart is relatively more. Now I've written one more term here, which is that there is sudden death in an athlete. Now, to be an athlete, you need to be physically fit. Somebody with hypertrophic cardiomyopathy cannot be expected to become an athlete at a state level or national level. I repeat my fact once again. Hypertrophic cardiomyopathy can be found in a young individual who died suddenly while he was playing football at a colony level, maybe with his friends, maybe knocking the ball around. I mean, when you perform at a state level or at a national level or at an international level, you really have to be physically fit. So it's highly unlikely that people with hypertrophic cardiomyopathy will attain that physical level of fitness that is required to play at a national level, or let me say at an international level. And we are having an athlete who's dying. Unfortunately, he is physically fit, and in the medical checkup of this guy, the sports medicine doctor, before he went for the competition, has done a checkup. There was no findings of hypertrophic cardiomyopathy. Still he died. Well, one of the reasons why this can happen is, and you do read about such situations, you do read about such conditions where a young individual who is medically fit and unfortunately he dies during a football match, that would be an athlete's heart. Now the question arises, what really happened with respect to an athlete's heart? I mean, what is the problem? Well, the problem in these patients is one that anyway athlete's heart would be bigger than a normal person because the person would be having a left ventricular hypertrophy. So we can understand the demand of the heart is more. But what happens during athlete's heart as a contributory factor for sudden death in an individual is that, imagine a guy, he's let me say running 3000 meter race or maybe a 10,000 meter race, and the last 100 meters are left. So in the last 100 meters, when you have already ran for 9,500 meters or 9,700, 800 meters, and the last 100, 200 meters are left, the guy will try his best. He's going to put a super Herculean effort. So his aorta is going to be super dilated and the pulmonary artery is going to be super dilated. Why? Because the heart is pumping more blood. The hypertrophied heart is pumping more blood, and what it can cause is kinking of his coronary artery. Yes, guys, the excessive amount of blood flow through the aorta can actually kink the left main coronary artery, or it can kink the right coronary artery, and they can be triggering of myocardial infarction in a patient. So in athlete's heart, the hypertrophied muscle of the heart, and it may not be necessary that it may only be left main coronary artery, it could be LAD also. The hypertrophied heart, coronary arteries are on the outside of the heart, the hypertrophied heart is working overtime. It might actually itself kink a coronary artery, and this kinking of the coronary artery will cause myocardial ischemia, and it can even trigger arrhythmia. It could be ventricular fibrillation, ventricular tachycardia, and the person could become pulseless. So athlete heart usually occurs during extreme amount of physical activity, where the grossly dilated aorta or the pulmonary artery or the hypertrophied muscle or a combination of all the things that I said might kink the coronary artery. But then another scenario could be that this guy is into mixed martial arts and he was punched in the chest. Mixed martial arts could be bare knuckles fight, so they could be punched to the chest, they could be elbow to the chest, knee to the chest. So in those circumstances, the person can still die. That would be a condition that is called as commotio cordis. When you read this term commotio cordis, it basically implies blunt trauma to the chest during a mixed martial arts fight. It could be wrestling, any kind of street fight also, brawl also, but usually he will talk about a professional fighter, and then he got a punch to the chest, and that resulted in unfortunate expiry of this person. The question again arises here, what really happened? I mean, what did the punch cause? It triggered a arrhythmia, but how? So I want to tell you the fact that the T wave, you see, we have a T wave which is responsible in the ECG for repolarization. If you read Ganong, the textbook of physiology, it says that the middle of the T wave is actually the vulnerable period of the heart. I'll say that again. The peak of the T wave or the middle of the T wave is the vulnerable period of the heart, because this is the time when half of the heart is depolarized, half of the heart is repolarized. So he says that if a punch hits the chest or a blunt trauma to the chest occurs right bang in the middle of the T wave, it can trigger ventricular fibrillation. A very surprising fact, but this explains why in Chinese martial arts, from a close, like in Kung Fu, you read about from like a short guy can kill a, let me say short guy, 5 feet 2 inches could kill a 6 feet 4 feet guy. How is that possible? I mean, those close punches to the chest and that repeated fast punching to the chest. So there's a possibility that the rapid punches that are being delivered, one of these punches might actually correspond to the peak of the T wave of this very tall giant wrestler, and this could trigger ventricular fibrillation in this wrestler. So we do read about commotio cordis as well, and then there could be cardiomyopathy, which is going to be relatively less common as compared to hypertrophic cardiomyopathy. I mean, I told you that the commonest one is hypertrophic. That's controversy with pathology, but there is no controversy with respect to the rarest variety. Restrictive cardiomyopathy, you very well know, is rare, but then I'm going to tell you something that is even more rarer, that is called as ARVD. And as the name suggests, ARVD, the alphabet A would be standing for arrhythmogenic right ventricular dysplasia. And if you read about the name itself, arrhythmogenic. So arrhythmogenic right ventricular dysplasia, or ARVD, is again a cause of sudden death, and that would be a sudden cardiac death. The special ECG finding of ARVD has also been discussed earlier. Like in WPW, I was talking about a delta wave. I'm just reminding you that epsilon wave would be found in ARVD. So with respect to an athlete, and I'm talking about an athlete who's participating at a national level, international level, then hypertrophic cardiomyopathy can be present. It is not that it cannot be present. It might have been missed, but it is relatively, I would say, lower down in the agenda. I mean, these that I have described before you, these 4 things that are described before you are not like they are in decreasing order of incidence, because we cannot have a comparison of 1 versus 2 versus 3 with respect to sudden cardiac death. But the point is, these are 4 important causes. I'm not saying that this data is in increasing order of importance or decreasing order of importance, but this is what we usually encounter. It could be athlete's heart, it could be I mean, if somebody is not into mixed martial arts, he is not going to have a blunt trauma to the chest, then it is arrhythmogenic right ventricular dysplasia which is to be considered, or hypertrophic cardiomyopathy, or the subtype of it, that is hypertrophic obstructive cardiomyopathy, is to be considered. Now I would like to zoom into this diagram and sensitize you to the fact that one of the problems that you encounter in these patients would be this septal hypertrophy. And apart from this hypertrophy, you are also noticing significant amount of left ventricular free wall thickness. In fact, I want to tell you the fact that this medical condition could be having left ventricular free wall thickness in excess of 3 centimeter. 1 inch would be approximately 2.5 centimeter. So left ventricle free wall thickness could be approaching as much as 3 centimeter. Imagine, I mean, heart wall is at least 1 inch or even thicker than that. So the amount of oxygen demand in the heart will definitely increase, and therefore in these patients you might have to put a ICD, that is a implantable cardioverter defibrillator. I mean, all the cardiomyopathies that we study are actually indications for putting a implantable cardioverter defibrillator, and this is one of the risk factors that can provoke or can trigger a sudden cardiac death. Now from the pathology part, I can say that if you look at this configuration that I'm just making before you, I'm going to make it once again. just look at the marking that I've just done, and you would realize that this looks like a cut end of a banana. So all of you have read about banana shaped cavity of the left ventricle is a feature of hypertrophic cardiomyopathy. I'm just putting that on record, though I know that you know that from your pathology classes also. Banana shaped cavity of the left ventricle is feature of hypertrophic cardiomyopathy, and also the size of the left ventricle is smaller. So if he says that is it a systolic disorder or is it a diastolic malfunction, it is a systolic malfunction, agreed. Especially when you read the word HOCM, it is definitely a systolic malfunction. But what is the primary defect in the patient? The primary defect is that if you combine or if you compare the size of the right ventricle with that of the left ventricular size is substantially reduced. So the primary defect in this patient is diastolic malfunction, and because the heart is coupled or designed like this, if there is a diastolic malfunction, it will contribute to, if input is lesser, output will be hampered, so it will translate into a systolic malfunction, but this would be answered as the primary defect in the patient. Another issue that I want to bring to your notice is that these patients would not be having a problem with respect to the aortic valve. Like I'm just putting alphabet A here for the aortic valve, this would be the pulmonic valve. The problem is not in the orifice of the aortic valve, but the problem lies here, right before or right inferiorly. This particular area that I have highlighted can be actually a subvalvular problem. When I say the word subvalvular, like in tetralogy of Fallot in pediatrics, you read subpulmonic stenosis. Today I'm teaching you for adult patient a subaortic stenosis, where the hypertrophic muscle in the heart, and you can see the leaflet of the valve, both of them are gonna act like a funnel, and it will restrict the amount of blood going into the aorta. The problem is not in the aortic valve, the problem is just below the level of the aortic valve. So one more information that can be added to the vocabulary here is over and above the banana shaped cavity of the heart, there would be a subvalvular aortic stenosis. Now, why am I interested in all of this is because this will be ultimately affecting the murmur which is produced here. You see, if every time is his stenosis, there will be a murmur present. Whether it is a subpulmonic stenosis of tetralogy of Fallot, whether it is a subaortic stenosis of hypertrophic cardiomyopathy, both will be responsible for development of a ejection systolic murmur, ESM. But this ejection systolic murmur will behave a little different from how the ejection systolic murmur of or let me say valvular aortic stenosis would be behaving. So one, I have put up these three important points for your reference, though some part of this would be repetition from pathology. But one of the important points to be remembered with respect to the behavior of this ejection systolic murmur is, and I'll just write down the entire theory so that questions with respect to I would say effects of standing or Valsalva maneuver, or let me say hand grip or hand shaking with the patient, how these maneuvers affect the intensity of the murmur can be understood from this particular statement that I'm making before you. The statement of mine is that all murmurs tend to decrease with Valsalva and with standing and with amyl nitrate, and the logic behind that is that when I say all murmurs decrease with Valsalva or with standing or with amyl nitrate, then the logic is that with respect to all of them, there would be a decrease in the venous return of the heart. And because of the decrease in the venous return of the heart, if the blood coming in the heart would be lesser, the output would also be lesser. But there is an exception to the rule, and the exception is what is to be understood. In a case of hypertrophic cardiomyopathy, I'll just move the slide superiorly. In cases of hypertrophic cardiomyopathy, the volume of blood in the left ventricle decides this gap that I have shown. If there is less amount of blood, then this separation will be lesser and this gap will become relatively lesser. I repeat my statement, if there is more blood inside the cavity of the left ventricle, then this gap that I've shown with gray and black color, this gap will vary. The gap that I'm talking about here is subaortic stenosis. If there's going to be lesser blood present, the gap would be lesser. If the gap is lesser, the murmur intensity will increase. On the other hand, if this gap is relatively more, then because there is more blood inside the cavity of the left ventricle, if the gap is more, the turbulence would be lesser, and therefore you would be having a lesser intensity of the murmur. So what I was saying was, and I'll just zoom I would to the actual statement. I said all murmurs would decrease with Valsalva, standing, and amyl nitrate, and the logic behind them would be that the less blood would be coming in the heart. But in HOCM, if less blood comes, that the gap that I showed you superiorly will become relatively lesser, and therefore the turbulence will increase. So hypertrophic cardiomyopathy is an exception to the rule. This murmur tends to become louder. Remember my statement, all murmurs decrease in intensity, or instead of writing decrease in intensity, I can use an alternative term which the MCQ can also use, that all murmurs become softer. With respect to Valsalva, standing amyl nitrite, all three behave in the same fashion, lesser amount of blood, except for hypertrophic cardiomyopathy that is louder. And one more condition, a term that can be added to this discussion is that even mitral valve prolapse murmur can behave a little different. But with respect to mitral valve prolapse, the terminology is again different. So let's just look at the terminology part and sort this out. Very closely related terms, and therefore high incidence of errors are what I have seen. HOCM murmur becomes louder, but MVP murmur becomes longer, and in the exam, that louder part and the longer part, some error of judgment can be present. So do remember this statement. In fact, I would suggest you to once for yourself write down this statement so that this gets imprinted into your memory. All murmurs decrease with Valsalva standing amyl nitrate except HOCM and MVP. The situations which I mentioned are the louder part and the longer part. Now, once we have got these names right, then we'll focus on the special characteristics that can be found in these patients of hypertrophic cardiomyopathy. So I'll focus on the examination findings of these patients, and these guys are unfit for recruitment into jobs where physical fitness is required. I mean, a guy with HOCM or HCM, if he's hired into, let me say, police or into army, or he becomes a pilot and he has to do strenuous physical activity, this guy may not make it. On physical examination in these patients, a special kind of pulse might be anticipated, that is the jerky pulse. The jerky pulse primarily occurs because when blood goes out of the heart of this patient, I'll just go back to my previous line diagram that I made before you. If blood has to go out of the heart of this individual, it would go out like this. This is like a speed breaker in the heart. So there might be a decrease in the velocity slightly before it is actually ejected into the aorta. You see this particular area, the valvular surface and the hypertrophied muscle, this whole area, the hypertrophied muscle, which is a waste of space, both of them are acting and are squeezing the outlet from the heart. And as I told you, I mean, the problem is not in the aortic valve, it's below that, but then it's like a funnel through which blood has to move across. So there can be a slight decrease in the velocity before the blood actually goes out into the aorta of the patient, thanks to this hypertrophied muscle which is acting like a speed breaker. And therefore the special finding of pulse that can be asked for this patient would say pulsus bispherians. So when I finish this topic, I'll also mention the ABCD of pulse, but then pulsus bispherians is an important term which is to be remembered. And a big textbook like Harrison, I mean, you can see that Harrison uses very perfect English, but here he has used a very casual term that would be jerky pulse, and that is just to signify that jerk comes because of outflow tract obstruction. To make it sound sophisticated, the MCQ will say dynamic, which means problem is occurring due to that hypertrophied muscle which is acting like a speed breaker during the phase of ejection when blood is going out of the heart. So when I'm saying movement is occurring, I said dynamic. And left ventricular outflow tract obstruction. So dynamic LVOTO is the reason behind development of pulsus bispherians, which can be felt in these patients. Then another feature that could be written in the MCQ to describe the significant hypertrophy of the heart of this patient, and there's a concomitant atrial hypertrophy also. So he might use the word double apical impulse. Whenever he writes these terms, like a double apical impulse, it anyway tells you that he's talking about hypertrophy of the left hand side, mainly the concentric variety. Then there would be mention of S4. You see, fourth heart sound is always present whenever the left atria of the patient becomes hypertrophied. Mark my words there, I did not say dilated, I said hypertrophy of the left atria will cause the left atria to generate more force. It will cause this atria to generate what is called as atrial kick, and this atrial kick is responsible for S4. So we call it atrial gallop, or we call it atrial kick. As far as the murmur in these patients is concerned, I've already sensitized you to this. This would be an ejection systolic murmur, and the intensity of this murmur will increase with standing, whereas traditionally the murmurs, they tend to decrease with standing. And this point has actually been asked in the previous years. in NEET PG. So I've just highlighted that statement because this is different from the routine ones. Now, for confirmation of diagnosis of this condition, a transesophageal echo will be done where a special finding would be present that is called as SAM. Normally, I just mention investigation of choice in cardiology for various conditions. Like for electrical problem, it could be either ECG or Holter. For where we are talking about valve problem, hypertrophy of the chamber, we are going in for echocardiography. But nowadays is also asking about the findings of echocardiography in these patients. So that would be a systolic anterior movement of the mitral valve. And I'll just go back to the diagram once again. This black structure which has been shown and is currently on the slide would be the mitral valve. So every time the blood is moving around in a jerky fashion across this area, there is a movement of the mitral valve also occurring. And mitral valve is responsible for filling of blood in the ventricle. Here during the phase of ejection, mitral valve is getting involved. So we are calling it a systolic anterior movement of the mitral valve. And from this you can also extrapolate the fact that in HOCM, if the treatment part is not given, even mitral regurgitation can occur in these patients because there's a valve displacement, so some jet of blood or some part of the blood might actually move into the left atria of these patients as well. As far as the treatment of this condition is concerned, from the drug perspective, we shall be using propranolol, which is a non-selective beta blocker. Traditionally in cardiology, I always talk about metoprolol or carvedilol or nebivolol. I'll talk about like carvedilol has a alpha blocking activity. Nebivolol would be nitric oxide releasing beta blocker. We talk about specific beta blockers in cardiology, the cardioselective ones. But a condition where a non-selective beta blocker is answered is propranolol. Along with this, oral antiarrhythmic is also given, that is disopyramide. And then he can also ask you what drugs are contraindicated. So all the standard drugs that we study, whether it be digoxin, whether it be nitroglycerin, ACE inhibitor, calcium channel blocker, all routine cardiology drugs are contraindicated in hypertrophic obstructive cardiomyopathy. Must know point for you guys. Why? The logic is simple. Suppose you're giving nitrates to this person for chest pain. What nitrates will do is they are vasodilator, so they will reduce the blood supply to the right side of the heart. If blood supply to the right side of the heart will become less blood will come to the left side of the heart, and already there is less coming to left. You see, in this condition, LV size was smaller, no? So if you decrease the blood supply coming to the right side, the blood supply to the left side will also reduce, and already there was less coming into the left, which means the fact that coronary blood flow will also reduce, because coronary blood flow is dependent on the amount of blood in the left ventricular chamber. You see, every time the heart will relax, then some blood will go in the coronary arteries, and if there is going to be less coming in the left ventricle, less will be going out in the aorta, and if less will go out in the aorta, less will be going in the coronary arteries of this patient. So coronary ischemia can be triggered by usage of nitrates. Let's take up ACE inhibitors. ACE inhibitors decrease preload, less would come in, less will go out. If less goes out in the aorta, less coronary blood flow, and if coronary blood flow is reduced in the patient, he is added, there would be coronary ischemia occurring. So all the standard cardiology drugs that you study in congestive heart failure are not to be given for these patients. It is propranolol and disopyramide, the antiarrhythmic, that can be given in these patients. And if he says that what is the treatment of choice for these patients, then do not answer drugs there. The treatment of choice that will reduce the mortality in these patients could either be surgery, or we can go in for an implantable cardioverter defibrillator. This device will read the heart 24/7, and if it will find abnormal rhythm, then this device has sufficient power to deliver a DC shock without the patient ever coming to know that a DC shock was delivered, and the patient would just be fine. So the treatment of choice for hypertrophic obstructive cardiomyopathy to increase the lifespan of the patient would be an implantable cardioverter defibrillator, though we also have surgeries available like myomectomy, and they could also inject alcohol. Traditionally we study alcohol as a cause of dilated cardiomyopathy, alcohol contributing to wet beriberi, high output heart failure. A therapeutic effect that we're using here is we inject alcohol into the septum. You see this useless part. And once you inject alcohol into the septum, if you get rid of this useless part in this case, once this useless part is gone, then the oxygen demand of the heart will also be lesser, and the cavity size of the left ventricle will increase. That will help in improving the survival of these patients. The aspects that are given on this slide are specific to hypertrophic obstructive cardiomyopathy, and what they can do in integrated questions is that they could also give you a histopathological slide for these also, and they can give a clinical history and then they can ask you to select from the slides which of these would be appropriate. So as the name suggests, for hypertrophic cardiomyopathy, you will be able to see myocytes which look relatively bigger, but they are all in a very irregular fashion. So one of the features of this particular slide is the disarray of the arrangement of the myofibrils. The statement I made was that there is a disorganized arrangement of the cardiac myocytes or myofibrils. In pathology books, they might actually not use this word disarray, but he might just say rolled pattern. Both of these terms or any of these terms given will make things relatively easier for you. The disorganized appearance of the cardiac myocytes and their thickness being relatively more, though the thickness is more, they're not generating more power. I mean, that's the ultimate dilemma in this case. The hemodynamics of the heart are like this. The heart is bigger, the heart is heavier, it is bulkier, it is more, it's having more muscles, but it's not able to generate because shape of the heart itself is one of the primary determinants for the efficiency of the heart. The ejection fraction is 65%. In these patients, the output of the heart would be limited. Then subsequently, you can notice some damaged myocytes. In fact, in the second slide that are shown before you, there is presence of damaged myocytes. And how can I say that they are damaged? If you look at these nuclei present, it looks like multinucleated. So it's like a fragmented nucleus here. So multinucleated myocytes would be present. Whenever you read these terms or if they give you a slide like this, you should be able to pick it up. And for the extreme right hand side, it would be relatively easier, still easier for you, because he's gonna describe a rare type of cardiomyopathy that is restrictive. And well, how are you able to pick up is this pink amyloid material which is present in between the cardiac myocytes, which will make the heart wall stiffer, and therefore the output from the heart would be lesser. This is primarily because of amyloidosis. Guys, I've done one more MCQ for you. The rarest type of cardiomyopathy, the number one cause for the rarest cardiomyopathy. I repeat my statement. The number one cause for the rarest type of cardiomyopathy happens to be amyloidosis. Though even it could be sarcoidosis, it could be even endomyocardial fibroelastosis, it could be radiation to the chest. The causes are, I'll enumerate again: amyloidosis, sarcoidosis, radiation, and then a disease which is more common for tropical countries is endomyocardial. I mean, read the name here: endomyocardial fibroelastosis. If you read the name itself, it tells you that this condition can cause fibrosis in the conduction system of the heart and damage to the cardiac myocytes as well, and the heart will become relatively more stiffer. Then as far as the findings are concerned for hypertrophic cardiomyopathy, I've already told you that the special pulse that might be written in the question would be pulsus bispheriens. This would be a jerky pulse, as I've explained. This jerky pulse, jerk comes because of a dynamic left ventricular outflow tract obstruction. In contrast, for dilated cardiomyopathy, the special pulse that would be mentioned is dicrotic pulse. Now, the specificity of the dicrotic pulse is that it is a twice beating pulse. I mean, the impulses would be coming twice. It's a twice beating pulse. And when I say this twice beating pulse, then the highlight is that this pulse is not only palpable in the phase of systole. Normally a pulse is palpable only in the phase of systole. This pulse is going to be present not only in the phase of systole but even in diastole. Guys, this is again very surprising, because normally you are able to appreciate a pulse only in the phase of systole. No, when the heart contracts, you are able to appreciate a pulse, but a pulse that can be felt both in systole as well as diastole is called as dicrotic pulse. Easy to remember: D for dicrotic, D for dilated cardiomyopathy. So one, you need to get these pulse features right for them, and there would be no specific pulse for restrictive cardiomyopathy, but the usual hack to solve this question would be presence of Kussmaul sign. I've described Kussmaul sign 3 times, that is constrictive pericarditis, restrictive cardiomyopathy, and then would be congestive heart failure. How would you differentiate whether it is restrictive cardiomyopathy or constrictive pericarditis? You can either go in for an endomyocardial biopsy. You see, if you go for endomyocardial biopsy, you can pick up the amyloid deposition in the heart, or there could be fibrosis due to the radiation component, or non-caseating granomas causing damage to the cardiac myocyte. That can be picked up by endomyocardial biopsy. But then endomyocardial biopsy will be a gold standard. If I want to differentiate restrictive cardiomyopathy from constrictive pericarditis, I can simply do a cardiac MRI. Cardiac MRI will show fibrosis when it comes to fibrosis in the myocardium When it comes to restrictive cardiomyopathy, it will show a flabby heart with respect to dilated cardiomyopathy, and it can obviously pick up the characteristics of hypertrophic, which will be even visible or will be easier to pick up even with the specific findings that I told you: banana shaped cavity of the left ventricle, hypertrophied free wall, asymmetrical septal hypertrophy, that can be picked up even with help of a echocardiography. So there will always be some features given, like I can add some more clinical features here, like for HOCM I told you ejection systolic murmur. In dilated cardiomyopathy, listen to this fact carefully. In dilated cardiomyopathy, the mitral and the tricuspid annulus will dilate. Due to dilatation of the mitral and the tricuspid annulus, there could be leakage of blood, and the patient of yours could be having either a functional tricuspid regurgitation or could be having a functional mitral regurgitation. Why I'm saying functional is because the problem is not of the valve leaflet. The problem is not of the valve leaflet. The problem is in the mitral annulus or tricuspid annulus, which is dilated. Like in, I'll explain a different way. Like in infective endocarditis, the leaflet is inflamed, or like vegetations of the valve leaflet are present. Leaflets are fine. It is the annulus that gets dilated, and therefore there could be a functional TR or MR, which could explain the presence of pan-systolic murmur in these patients. So murmur will also give you a hint. As far as fourth heart sound is concerned, this would be specific for hypertrophic cardiomyopathy and even restrictive cardiomyopathy, where we have a bigger or enlarged atria. And the reason for atria can be enlarged even in dilated cardiomyopathy, but it's a flabby heart. Dilated cardiomyopathy, the word is flabby. Whereas when it comes to restrictive, it's a stiff heart, and to fill blood against stiff ventricles, listen to my words carefully, if you have to fill blood in a stiff heart, the stiffness could be either due to constrictive pericarditis or due to stiffness due to restrictive cardiomyopathy. If the atria has to work against a resistance, they can be left atrial hypertrophy anticipated. I did not say left atrial dilatation. I said left atrial hypertrophy can be anticipated, and that left atrial hypertrophy will generate more force, so that will generate S4 in these patients. So there would be a lot of pointers given in the question with respect to the descriptions of these patients, and with respect to histopathology anyway, because integrated is what they love to ask. You can be very thorough with these slides there. Plus echocardiography can help you in identification. Cardiac MRI can be done. I mean, very good emerging technique nowadays is cardiac MRI. In fact, even in the myocarditis topic, I talked about cardiac MRI. Like nowadays, instead of doing endomyocardial biopsy, most of the latest studies talk about cardiac MRI being done. So cardiac MRI can pick up problems in the muscles, or it can pick up problems that would be lying outside the muscles as well. So this would be one imaging modality. I'm not saying that this is the only imaging modality. I mean, we can obviously use echo also and judiciously come to conclusion what type of cardiomyopathy is present. It is not that we could not make a diagnosis of cardiomyopathies subtypes 20 years ago when we did not have a cardiac MRI. That has come right now. But this imaging modality is the one which is being used nowadays more extensively to study the structural defects in the heart. I mean, apart from echocardiography, cardiac MRI is being used to study the structural defects in the heart, especially with respect to the myocardium and the pericardium part. This would be fairly sensitive. Otherwise, another technique that I can just say, without writing it down, is that, let me say you don't have any other facility, but you are having a CT chest. So CT chest can pick up calcification outside the heart, constrictive pericarditis, which is an important differential diagnosis of restrictive cardiomyopathy. And suppose you are not able to, from the clinical history, pick it up, because there would be stiffness in the heart. So right ventricle will also be non-compliant, left will also be non-compliant. If right is non-compliant, there could be elevated JVP, there could be hepatomegaly, pedal edema. If left side is not compliant, there would be pulmonary edema. The question will look like, let me say, heart failure case. The biggest way or the simplest way I can tell you clinically to identify constrictive pericarditis, where findings can be same as that of restrictive cardiomyopathy, because stiffness is the common thing between the two, the word pericardial shudder. If you read auscultatory finding of pericardial shudder or pericardial knock that I've described in the earlier part also with respect to diseases of the outside of the heart, that would be the best clinching point to differentiate restrictive cardiomyopathy versus constrictive pericarditis. In constrictive pericarditis, you will be reading Kussmaul sign, RCM also Kussmaul sign. So Kussmaul sign will not differentiate. It is the auscultatory finding of pericardial shudder or pericardial knock or pericardial shock that was taught to you earlier, that would help you differentiate between these particular conditions. Now this discussion also gives me the leverage to talk about the mnemonic, that is ABCD of the various varieties of pulse. So let's have a look at the various types of pulse that could be given to you, and one of them would be anacrotic pulse. As the name suggests, anacrotic pulse, this would be a slow rising pulse. The pulse will rise very slowly. The reason for this would be a outflow tract obstruction, that is there is a valvular aortic stenosis. Not only the pulse is slow rising, but at the same time I said this pulse will also be having a decreased amplitude. That is understandable because if there's a physical obstruction, the amount of blood going out of the heart would be relatively lesser. So this anacrotic pulse can also be written in the book as pulsus tardus et parvus. The point I'm trying to make here before you is that there are different terms which are used which can cause error of judgment. In the ABCD of pulse, alphabet A is to be remembered mainly for anacrotic pulse. That's the alternative term that I mentioned, and this would be answered by you for a person who's having valvular aortic stenosis. Aortic stenosis usually occurs in extreme age groups. Usually there's a calcification of the valve in 75-80 years of age, or it is seen in pediatric age group due to rheumatic etiology, but aortic stenosis is unlikely to be seen at your and my age. Now moving ahead, the second pulse that we'll study here is pulsus bispherians, the name of which is I've already said, but I'll just explain that again to you. Pulsus bispherians is called as a jerky pulse. The reason for this jerk is a dynamic left ventricular outflow tract obstruction. Pulsus bispherians is a slow rising pulse. Well, this slow rising pulse is found in hypertrophic obstructive cardiomyopathy, a must know fact for you. Third one is easier. When I describe it, it's easier for most people to pick up. That would be collapsing pulse. In collapsing pulse, you would be raising the arm of the patient, like you were checking out the pulse of this patient, then you raise the arm of the patient above the level of the head. When you raise the arm in a normal person, the blood will tend to go towards the heart, but it's not going to go back into the heart. The reason why that's not going to happen is because you and me have a compliant aortic valve. It's not going to allow a single drop of blood to go back. But in patients of aortic regurgitation, the blood can go back into the heart, especially when it's anyway going back into the heart during the phase of diastole, because valve leaflets are defective. If you raise the arm of the patient above the level of the head, then the blood tends to flow back into the chamber of the left ventricle. So we call it a collapsing pulse, and this would be seen in valvular aortic regurgitation. Because this is easier, so there's a possibility that when you attempt questions, instead of saying the word collapsing pulse, he might use words like Corrigan's pulse as well. So both imply the same. Alphabet D is again easier to remember. That would be dicrotic pulse. I had already told you the fact that pulse is palpable only in systole. But if you're going to have a pulse where one component is in the systole, other component in the diastole, I'm going to call it a dicrotic pulse. So ABCD of pulse, just get the names right. This is A, B, C and D that I've highlighted for the conditions. And must know right now, right here would be bispherians and dicrotic. Very classical names. So I mean, you read them and these would be cues, visual cues that would help you pick up the condition. Over and above this, additional pulse that I can mention is called as pulsus alternans. In the earlier part of the discussion, I have talked about electrical alternance. Now pay attention to the words here. When I say electrical alternance is what you encounter with pericardial effusion and subsequently cardiac tamponade. But pulsus alternance means that there would be alternatively weak pulse impulse, then there would be a strong pulse impulse, then again a weak pulse impulse. So this alternatively weak and strong impulses that come, this would be a feature that is encountered with left ventricular failure. So alphabet A coming up once again for you, that is pulsus alternans. And apart from this, irregular pulse can be found in tachyarrhythmias. And one of the important tachyarrhythmias where irregular pulse can be present is atrial fibrillation, along with which even pulse deficit would be present. So this anyway are, I would say, an important slide from the perspective that it helps you pick up the condition that the examiner is trying to put up before you. Now coming to the subsequent topic, which is a disease of the aorta, aortic dissection has been asked. I'll just zoom into the image which I've hand drawn before you, and there was the CT chest of the individual given. You can pick up the lung architecture here. The blood vessel which is present, and I marked at the moment is the pulmonary artery, and then it's bifurcating into the two. Posteriorly, you can see the descending aorta, and anteriorly, you can notice a intimal flap in the ascending aorta of the patient. And well, this tells you that this patient would be having a type A aortic dissection. The logic to be simply used here is that if you find this kind of an intimal tear, which gives the configuration to the aorta as that of a tennis ball, then anteriorly present it is type A aortic dissection. Suppose hypothetically speaking, if the same kind of a intimal tear or a flap was visualized in the descending aorta of the patient, then you will answer as type B aortic dissection. Now, why that is important from the exam perspective is because in type A aortic dissection, you always have to go in for surgery. But for type B aortic dissection, if the patient is still able to maintain his blood pressure, then you might be using a short-acting beta blocker like esmolol to control the heart rate and prevent the propagation of the tear. But if the BP of the patient starts to crash and goes towards unrecordable, then surgery would be required. The main reason why I'm discussing this topic of aortic dissection is just to highlight this fact that if it is type A, it's always answered as surgery, and in type B, depending on the blood pressure values in the question, the answer would be given. Like I'm saying, the BP of the patient is normal to low, then I can be using a short-acting beta blocker, that is esmolol. Esmolol will obviously not repair the tear which has occurred. It is just gonna slow down the propagation of the tear. But if you have a crushing patient, then in those circumstances, surgery would be done in the case immediately. The MCQ will usually describe a known case of hypertension coming to your hospital with chest pain at rest. So when you're gonna read the question the first time, the impression in your mind is hypertensive patient with chest pain at rest, which might be for 3 hours, 4 hours. You might be thinking that this could be myocardial infarction. But then the question will use some very characteristic terms that I want you to pick up. Like traditionally in MI, when you ask the patient to describe the pain, most patients will put their whole hand on the chest or fist on the chest to describe the pain, which I told you is Levine sign. But in a MCQ of aortic dissection, the characteristic history will be chest pain is present. But when you're asking the patient to put his hand on the chest to describe where the pain is, the patient was doing like this. He might have told you chest pain, but he might say that the pain is also radiating to the back at the end, the way I'm putting my hands at the movement. So this particular multiple choice question would give you a very important hint that the question would be saying that the chest pain of the patient is radiating to the interscapular area. You see, in MI, the pain can radiate to the angle of the jaw or to the root of the tooth, or pain in MI can radiate to towards the abdomen or right up to the umbilicus, which would be dermatome T10. But in this case, the chest pain is radiating to the interscapular area, which would be a very good pointer. And as far as the number one cause of aortic dissection is concerned, why does somebody have a tear of the aorta? Then the answer is hypertension. Yes, you get aortic dissection in Marfan syndrome also. You get it with cystic medial necrosis also. But if he says what would be the overall number one cause, then your answer would be given as uncontrolled hypertension can cause an intimal tear, and the tennis ball appearance is what I've shown before you. In these patients, there can also be retrograde tear occurring. The retrograde spread of the tear would be a disaster because then the tear will go into the coronary arteries. So these patients can even end up with coronary artery dissection, and you can understand that thrombolysis would not be effective at this particular point of time, and the patient would be developing a type 1 myocardial infarction. Now, as far as the imaging modality of this question is concerned, then there will always be a controversy, and you would have encountered questions on the controversy that sometimes it will be written transesophageal echo, and in comparison to that, he might be talking about either a MRI chest or a CT chest of the patient. Now, when to answer when, what I can say is if the patient is hemodynamically unstable, then to transfer him to a radiology department and do a MRI chest or a CT chest would be a little, I would say, dodgy or difficult to perform. The person might die on the way on being taken to the radiology department. So I would like to go in for a transesophageal echocardiography. So if it describes a crashing patient, unstable patient, then I would recommend you to answer as transesophageal echo. And if the BP is still holding at the moment, if the patient is hemodynamically stable, then we can go in for either a MRI or a CT chest. And the CT chest finding that I have told you today would be again important, and is the main reason actually why we are discussing all this is the tennis ball appearance. As far as the treatment part is concerned, I've already told you in type A it's always surgery. And there are two classifications which can be used for this one, and most of the time in the exam they love to ask about Stanford classification because this it is simple and straightforward. Type A would be that any kind of dissection that involves the ascending aorta irrespective of the site of origin, and if it's gonna be all dissections which are not involving the ascending aorta, that would be descending aorta arch subsequently, then I mean mostly in the exam it is type A and type B that you need to give importance to. And the only reason why this question can go wrong, everything is very characteristic, tennis ball appearance or chest pain interscapular area. The usual reason I find it goes wrong is the etiology part. I mean, we start thinking in terms of aortic aneurysm causes, whereas this would be hypertension uncontrolled, which will cause a tear in the tunica intima, then in the media, and there would be a false lumen created in the lumen of the aorta itself. I mean, after all, aorta is a blood vessel, so in the wall, I'm talking about the wall of the aorta would be having a false lumen created. Moving subsequently, the topic we are studying is infective endocarditis, and here I'll be focusing on the Duke's criteria, the modified Duke's criteria for diagnosis. Traditionally, in Jones criteria, we have clinical features as major ones, but in infective endocarditis Duke's criteria, it would be rather investigations which are the major ones. So we'll be doing a blood culture, or we can be doing a echocardiography. Blood culture would be consistent with the standard organisms. If it is acute bacterial endocarditis, it could be Staphylococcus aureus or it could be Streptococcus. And especially if he uses the word community acquired, then it would be answered as Streptococcus. But for hospital acquired, it would be Staphylococcus aureus. But if he says the word subacute bacterial endocarditis, then your job is relatively easier. Then it would be Streptococcus viridans. As far as the organisms part is concerned, that is covered in microbiology component also. The only possibility of error is in acute bacterial endocarditis, as I highlighted. I mean, if he specifies that the person was admitted in a hospital and subsequently there has been an episode, so then your answer would be given as Staphylococcus aureus. But if it is not gonna be hospital acquired, then it would be Streptococcus also. That should be remembered from the community perspective. Now he might even say IV drug user, and he might say right-sided endocarditis. So when I say IV drug user, infective endocarditis, it's tricuspid valve that would be affected, and this person may not maintain hygiene, and as a result of it, I mean, when he's taking the IV drug, there is infection going into the right side of the heart. The organism in this particular case would be again Staphylococcus aureus. As far as coagulous negative Staphylococcus is asked, that is cons, that would be mainly for prostatic valve endocarditis. So because we are focusing on the organism part, that is why I said that you need to go in for a blood culture, and these blood cultures should be at least, I mean, ideally speaking, it should be at least 3 blood cultures. Like you might be taking a total of 4, so at least 3 blood cultures that are taken at least 1 to 2 hours apart would help you in identifying or diagnosing infective endocarditis. They've asked only time when only 1 culture positive will be sufficient for diagnosis, then your answer would be Coxiella burnetii. I repeat that again. Traditionally, you will take multiple blood cultures, and at least, ideally, I would say all 3 out of 4 that I've taken at a gap of like 1 to 2 hours. Now, why that gap is important is because of the fact that you see, I want to prove that the heart is the source of bacteria into the systemic circulation. So I would like all the 3 reports to be positive with the same organism. But suppose he says only 1 culture report is positive out of 3, and which would organism would be suspected, then it is the organism causing Q fever, that is Coxiella burnetii. So apart from the organism perspective, he cannot talk about echocardiographic findings, and the echocardiographic findings I can explain in the line diagram that I'm making now before you. You can take this to be a representation of the aortic valve leaflets, and then superiorly I've shown the aorta. You could be having bacteria and fibrin growing on the surface of the heart valves. So I just modulated the diagram to say that the aortic valve is having vegetations. In fact, these vegetations can grow deeper, and they can grow into the tissue of the valve. So you might even use the word valve abscess. So whenever you read about valve abscess, or whenever you read regarding ring abscess, With respect to infective endocarditis, it simply means that the infection has gone deep seated and it is causing extensive problems in the patient. What I mean by extensive problem is the bacteria is eating away into the tissue of the valve, so it could actually result in a perforation. You see, I'm not describing a standard aortic regurgitation where valve leaflet apposition is defective. What I have tried to highlight in this particular diagram is that as far as the apposition of the valve leaflets is concerned, let me just improve upon this diagram here. As far as the valve leaflets are concerned, there is no problem. As far as the cusp of the valve is concerned, no problem. Like in rheumatic, I always say it is the cusp of the valve or the tip of the valve that's involved. We call it commissural end involvement. But in this case, the commissural end where the valve cusp is touching each other, that's not a problem. Rather, what is happening in this case is that there is a perforation in the valve leaflet. So this perforation in the valve leaflet would cause blood to go back into the left ventricle. In you and me, not a single drop of blood will ever go from aorta to the left ventricle, but here there's a leakage of blood. That is the reason why he will say the word new onset murmur, and that's a important major diagnostic criteria. So let's just summarize the three important major diagnostic criteria for infective endocarditis. The number aspects to be remembered is blood culture is pretty straightforward because you obviously need to isolate the organism. Then is gonna be echocardiographic evidence. Then is the new onset murmur that I was talking about, or it could be a pre-existing murmur that would have worsened because the valve leaflet in the person has been affected. So mainly it is 3 points: blood culture, echo, and new onset valvular lesion. Then we'll talk about the minor criteria. One could be fever, then could be predisposition. Predisposition may not always be IV drug usage. There's a possibility that he might mention that this is a known case of rheumatic heart disease who has been having fever for past 2 weeks, this child. Or he might say this is an alcoholic with structural heart disease and he's been running fever. Anytime there is structural damage to the heart, there is structural damage to the valve leaflets, infective endocarditis can intervene. The person would be having fever, then vascular phenomenon. One of the important vascular phenomenon that they love to ask is Janeway lesion. And where would you look for these Janeway lesions would be in the palms and the soles of the patient, because Janeway lesions would be erythematous macules in the palms and in the soles. Then he will talk about immunological criteria. The immunological criteria can be remembered by mnemonic by the name of ROG. ROG would stand for R would be Roth spots, then would be R again for positive rheumatoid factor. It's biologically false positive. Traditionally rheumatoid factor is for rheumatoid arthritis, but here it is biologically false positive. So alphabet R will be used 2 times. I repeat again, one would be for Roth spots, second would be for rheumatoid arthritis. O would be Osler nodes, the famous Osler residency in America and Harvard. The Osler nodes would be in the pulp of the finger or in the fingertips, and then would be G would be glomerulonephritis. Again, it looks, hematuria as a word. I mean, when you're reading infective endocarditis, you're focusing on the heart, and he might actually mention that RBC is in the urine because there is a glomerulonephritis component present. So that's a minor diagnostic criteria. And why is Roth spot a minor diagnostic criteria? Because they are found on a fundus examination. So something as important as a finding of fundus should be taken as a major diagnostic criteria. Well, Roth spots can also be seen, and this is again a previous, there before NEET PG, the word used was AIPG. So it's a previous AIPG MCQ that Roth spots can also be seen in. So very surprising answer. Roth spots can even be seen in anemia. Roth spots can be seen in patients with leukemia and infective endocarditis. So there is no big deal for finding Roth spots on a fundus examination, because they can be found in other conditions also. They would be called as a minor diagnostic criteria. And if, let me say, the cultures are not satisfying the diagnostic criteria that I said superiorly, I mean, ideally as many cultures just out of 4, 3 should at least be positive. If they're not matching the superior criteria, the major ones, then we'll include them in minor. And for diagnosis of this condition, you need at least 1 major and 3 minor criteria. And there is also a possibility that the person might have taken antibiotics before he actually came. He might have taken antibiotics from a private setup before he came to you. As a result of it, his blood culture might actually turn sterile. And the vegetations, if they're smaller than 2 millimeter, they may not be seen on echocardiography. I mean, you can visualize the left ventricle, you can visualize the aorta, but then vegetations, if they're less than 2 mm, they may not be seen. So the textbook also says that if the major criteria are not present, and when major criteria like if vegetations are small, there would be no perforation in the valve leaflet. And if there is no perforation in the leaflet, then this new onset murmur will also not be happening. The green vector that I've shown here shows a new onset murmur due to perforation in the valve leaflet. So if the vegetation is small, damage is limited, there would be no perforation present. So what I'm trying to explain to you is that major criteria may not be present also. Then you will base your diagnosis on the basis of 5 minor criteria, and obviously laboratory tests here are positive in the form of blood culture or echocardiography. Any one, if present, is sufficient for diagnosis. Infective endocarditis has a issue that it will be always, the risk of development of infective endocarditis is directly proportional to the mathematical shunt gradient. Let me say I incorporate conditions like mitral regurgitation, then aortic stenosis, and then ASD. When I say mitral regurgitation, that would be the valvular heart condition operating at the highest pressure gradient, so highest chances of infective endocarditis would be present. Whereas when it comes to AST, it's a low pressure shunt, so the gradient would be relatively lesser, and therefore the chances of infective endocarditis would also be lesser. So people who are having pre-existing heart disease, or they are having a prosthetic heart valve present, then these patients should be taking special prevention whenever they are going in for a dental procedure. Like the person is having a cavity in the tooth and is getting a root canal treatment, and there's a pulp abscess also. Because if a person is having dental caries, if a person is suffering from dental caries, then during the dental procedure there could be possibility of inoculation of bacteria into the bloodstream, and they could actually cause damage to the heart valves. As a result of it, in patients with dental caries, before the procedure we will be giving ampicillin. This would be about 2 grams of ampicillin, which can be given 1 hour before the procedure. The reason why we are doing this is to mitigate the risk of development of damage to the heart valves. So what are those patients who would be requiring such a aspect? I would also like to tell you that this prophylaxis that I have mentioned with antibiotics, this prophylaxis is valid for dental procedures only. However, it is not valid for genitourinary procedure, like if a person is undergoing a cystoscopy or if the patient is undergoing a colonoscopy, then there would be no need for giving antibiotic prophylaxis. Any person with a prosthetic heart valve disease, you see already there is a artificial heart valve. I don't want to take a chance and let it get destroyed. If this this device is used for heart failure, so this is a device in the heart. So left ventricular assist device is useful for heart failure patients who are actually having a heart failure so severe that they need a transplantation. But before they get a brain dead donor, you need a bridge. And what I mean by bridge is this artificial left ventricle. Medical science has not been able to produce a whole of a heart, but we have been able to produce at least a chamber that supports the left ventricle. So we call it LVAD, that is left ventricular assist device. And the speciality for point number 1 and point number 2 would only be the fact that in both of these conditions there is a device in the heart. So I would like to, because I put an artificial heart valve, I would like to prevent it from any kind of disintegration. Similarly, if somebody has already had some development of prior endocarditis, because there is already damage in the heart valve, I don't want to take a chance. And then congenital heart disease word comes in here 3 times, that is for cyanotic heart disease. You see, if a person is having unrepaired, in fact, I'll just clarify this here also, that if a person is having, let me say, tetralogy of Fallot or tricuspid atresia, and that too of the cyanotic variety, because let me say tetralogy of Fallot, then this would be having ejection systolic murmur. When I say systolic murmur, it means it is operating at a high pressure gradient. So even if it is unrepaired or repaired within the first 6 months, or some residual defects are present, then for these patients, a cyanotic heart disease, because cyanotic heart disease like tetralogy of Fallot can be having subpulmonic stenosis and a high pressure gradient in the heart, so they would require prophylaxis. As far as point number 5 and 6 are concerned, they are only for completion. Transcatheter pulmonic valve, like we can put us like nowadays with help of there's no need for open heart surgery. You can deploy a aortic valve via the femoral. You can go via the femoral artery retrogradely. So you can deploy a transcatheter aortic valve. We can deploy a transcatheter pulmonic valve. Obviously, for pulmonic valve, the route of entry will be via the veins, like basilic vein. And if I want to go to left side of the heart, I'll go by artery. But the point is, if a person is having a transcatheter artificial heart valve, I would like to protect it. And if a person is having valvulopathy after cardiac transplantation. In fact, these aspects that I have mentioned were just asked in the recently conducted 21st May exam, and I'm just showing the snapshot to you at the moment. In this NEET PG question, he said a 25-year-old guy with dental caries is undergoing a dental extraction. So which of the following condition does not need prophylaxis for endocarditis? You can see if a person is already having endocarditis, if there's a prostatic heart valve disease, if there's an unrepaired, untreated cyanotic heart disease, all the three things which you currently see on the slide are situations where you have to go in for antibiotic prophylaxis. But because the question said not needed, then AST is a low pressure shunt. Atrial septal defect operates at a pressure difference of only 4 millimeter of mercury. So antibiotic prophylaxis would not be required. So nowadays in the topic of infective endocarditis, instead of talking about organisms from medicine perspective, he usually tends to focus more on when would you like to go in for antibiotic prophylaxis, and even in the main videos this is given right in the end. Next on the agenda would be a disorder that has a pediatric overlap as well, that is rheumatic fever and rheumatic heart disease, which would be caused by group A beta hemolytic streptococcus. It is an example of type 2 hypersensitivity reaction, and you are familiar with the Jones criteria. Now, Jones criteria, they always had a prefix written 1993 update for Jones criteria, modified Jones criteria. But now what they're doing is, and that's what is also mentioned in the current edition of Harrison, they've mentioned regarding the 2015 update of the modified Jones criteria. So let's look at how they have gone about it. And one of the important parameters which is actually given at the bottom of this modified Jones criteria is dividing the discussion into low risk population versus high risk. High risk population would be a country like India where incidence of sore throats would be more, and low risk would be like America. And just to give you, a basic underline before I mention the definition of low risk case per se, which is anyway on the slide, let us assume an Indian patient who's having one of the features of rheumatic fever, that is migratory polyarthritis. Now the disease is so common in India that the progression of the disease is, first you would be having suppose ankle joint swelling, then it migrates to knee joint of the contralateral side, maybe then maybe to the elbow joint. So because the disease is common in India, he says that you don't need to wait for evolution of the full picture of the disease, that is multiple joints getting involved over a period of time before you say, okay, this is one of the diagnostic criteria for rheumatic fever. He says for a country like India, even if it is going to be, let me say, population which is high risk, even if it is a single joint involvement, we can take it as a diagnostic criteria. But for a country like America, where it is relatively rare, you will have to consider and wait for the involvement of multiple joints before you say that, okay, this is going to be the arthritis component. So in earlier times when I was a student at your age, we only used to read polyarthritis. But you can notice for low risk population, he has mentioned polyarthritis. But for a country like India, he's saying that even if monoarthritis is present, it is an important diagnostic criteria. So one of the important changes which can be incorporated in MCQs can be that he can deliberately write monoarthritis as well as polyarthritis. And both statements are correct depending upon the endemicity or depending upon where per se the case is occurring. I mean, which part of the globe is the case occurring. And before I go into more details, let us just finish the definition of low risk. And that is again important because it is given at the bottom of the table. So it looks very inconsequential, but the numbers anyway have to be remembered. It is 2 cases or lesser than that when we are talking about the denominator for school age children. But suppose the denominator given here is all ages, because anyway, rheumatic heart disease can occur in adult age group as well. Then the denominator would be 1000, and this would be less than 1 case. So do remember, before you answer 2, less than 2 or less than 1, have a look at whether he is asking for school age children or whether he is asking for all age population. As far as the criteria are concerned, the mnemonic that we use is cases, and the first one that we encounter is carditis. With respect to carditis, there can be 3 manifestations. It could either be pericarditis, myocarditis, or endocarditis. The pericarditis component will cause chest pain. The Ashcroft nodules which are present here will cause irritation of the outermost surface of the heart. So this child will be having chest pain, and one of the auscultatory findings that you will encounter here with respect to pericarditis would be a pericardial friction rub. How would you differentiate between a pericardial friction rub and pleural rub? You will ask the patient to take a deep breath and hold it there. If there is going to be an auscultatory finding which tends to disappear on breath holding, that it can't be a pleural rub. Pleural rub is coming from the lungs. So if the sound is persisting in spite of holding the breath, it is a pericardial friction rub. And this pericardial friction rub will be associated with ECG finding of ST elevation, which will be concave in upward direction, and the child would be having chest pain, which can be managed with steroids. But if it is going to be myocarditis, then the manifestations will be more severe because the Ashcroft nodules are causing inflammatory changes in the muscles of the heart. So there's going to be a development of heart failure. This heart failure can contribute to dilatation of the mitral valve annulus or the tricuspid valve annulus, as a result of which there would be even a pulmonary edema coming up. Like I said, there's a dilatation of the mitral valve annulus. The heart is dilated itself. So there is a MR, and this functional MR can contribute to, and mark my words there, at the moment there is no commissural damage. There is no damage to the chordate and tendineae. It is simply the muscles of the heart, the myocardium, which has been involved. I haven't even said the word endocarditis. This is myocarditis involvement causing a dilatation of the heart and thereby contributing to pulmonary edema. So I will talk about valve involvement. I will talk about endocarditis that occurs in these patients. But what you have to realize is that at the moment, in the early phase of the disease, you could be having mitral regurgitation without actual damage to the mitral valve leaflet, because there is a dilatation of the mitral annulus because of the myocarditis component where the heart is dilated. Now, when it comes to the endocarditis component, they would obviously love to talk about it. One, because of the fact that once there is an endocarditis component occurring, he might ask you that which is the commonest valvular lesion that would be developing. Now, if he says what is the commonest valvular lesion that would be occurring, the answer is standard mitral stenosis, but that is valid especially for adult patients. As I said, this is valid for adult patients, but if he says what is the commonest valvular lesion with respect to a child, then in those circumstances, if he says child, then the most common valvular lesion should be answered as mitral regurgitation. Please remember, mitral stenosis takes time to develop. You're not going to have it develop relatively early. So the answers are to be given on the basis of the age. Another thing that they can ask you with respect to the endocarditis involvement is, and I'll try to draw a hand diagram of it, but the technical word is commissural end involvement occurs in mitral valve cardiac involvement. Let me just draw a diagram so that I can explain this commissural involvement relatively better. Let us assume this to be, let us say, the left ventricle. This is the mitral valve leaflets that I have shown. So Ashcroft nodules could be occurring on the heart valve per se, like Ashcroft nodules could be present on the surface of the heart valve. Let us take this to be the superior surface. Ashcroft nodules could be present at area number 2, that is the inferior surface. But Ashcroft nodules are present in higher concentrations at the following area, which are marked as area number 3, that is where the valve cusps are touching each other. This is what I was saying meant by the word commissural end involvement in rheumatic heart disease. And because of this commissural end involvement, what's going to happen ultimately is that there could be leakage of blood. This blood could actually be leaking across from left ventricle to the left atria, and the result of this leakage of blood is that there is a development of a murmur as well. In fact, that's one of the characteristic murmur of rheumatic heart disease. And one of the more very important statements that I want you to remember for today is that the characteristic murmur of rheumatic heart disease is what is called as a Kerry-Coombs murmur, in which at the moment what you can see is that the blood would be leaking from the left ventricle to the left atria. But then whichever blood, the amount of blood which is leaking here is very minuscule, but this blood that leaks from left ventricle to the left atria has to come back also. So when this blood is going to come back from the left atria to the left ventricle, that is when it's going to generate a diastolic murmur. The way I've drawn it, you see, the query of most of the people is that, sir, if you are describing blood leaking from LV to LA, it should be called as a pansystolic murmur or a early systolic murmur or mitral regurgitation. I agree that the arrows that I've drawn here initially show blood leaking from LV to LA, which occurs in the phase of systole. But this amount of blood is very minuscule. So because the amount of blood is very less, it may not produce any noise. Mark my words there. I said may not produce any noise. Now, once the blood becomes substantial in the lumen of the left atria will get dilated, and this blood would now come back to the left ventricle, because after all the heart is in a state of continuous motion. So it's not that the blood that goes into the left atria is going to remain there. So this blood will ultimately flow back into the left ventricle, which is why this is a flow murmur and is a diastolic murmur. So I mean, these arrows could cause errors of interpretation, is why I have decided to draw this line diagram here. Commissural end involvement and a Carico's murmur is one of the characteristic features of rheumatic endocarditis. And then they can also ask you which valve is commonly involved and which valve is usually not involved. So for the valve which is commonly involved, nobody would make a mistake. Mitral valve is the most common valve that is involved. But in the same spirit, I want you to remember that when it comes to the pulmonic valve involvement, pulmonic valve involvement is either not mentioned in books, or in some books of pediatric cardiology it may be written, it rarely may be involved. So both perspectives have to be remembered. The learning is that just like you are comfortable with mitral being most commonly involved, you have to be comfortable with the pulmonic valve being rarely involved in these patients. Apart from this, you could be having alphabet A coming up, that would be arthritis. Now, when I'm describing the arthritis component, though I have given a shorter description, let me just say that again. Traditional word is migratory polyarthritis. Like the child may not go to school one day because he was having the difficulty in walking. The parents noticed child was limping and he was complaining of pain in the right ankle joint. Now, after a few days, this swelling, they might show to a doctor also, he might give some treatment also, but this swelling will disappear from the ankle joint and will reappear at a different joint, maybe 2-3 days later. So the parents again back to the doctor, see doctor, earlier he was having ankle joint swelling, now he's having a knee joint swelling. Then the swelling will move on to, let me say, the elbow joint. So upper extremity could be involved. The message is the arthritis jumps from one large joint to another. So we call it migratory polyarthritis, and this must be satisfied for a case that is occurring in USA. But for a country like India, he says the fact that you don't need to wait for all these manifestations to occur. Even monoarthritis is taken as a diagnostic criteria, and even polyarthralgia. The word is joint may not be inflamed and red, but he might be complaining of pain in the joints. So both of these words are important because, as I said, when I was a student your age, we used to read only migratory polyarthritis, but words like monoarthritis and polyarthralgia are also taken to be diagnostic criteria. Similarly, one more change that I can say from the carditis component is that I don't need to wait for the commissural end involvement to occur and Carico's murmur to occur and then MS and MR to occur to diagnose rheumatic heart disease. You see, if there is going to be inflammation of the valve cusps, in fact, what I said was the commissural end involvement. Let me describe it another way. The inflammation of the valve cusp can be called as valvulitis. And this valvulitis can be picked up on the basis of echocardiography. So at the moment, echocardiographic findings have been included in the diagnostic criteria of rheumatic heart disease, which was not the case in the earlier sense. You know, when I was a student, all we used to read was wait for the person to develop full-blown features of carditis. We used to literally wait for, okay, MS murmur is heard or not, MR murmur is heard or not. But now he says, why do you want to wait? I mean, in a scenario of evidence-based medicine where we are advancing every day, we should try to diagnose our cases early. That is why echocardiographic finding of valvulitis, that's why it is written clinical and or subclinical. Even echocardiographic findings are well taken as diagnostic feature. So apart from the carditis and the arthritis component, in fact, arthritis is an early feature. You are aware of that arthritis can occur as early as within 2-3 weeks of a sore throat. But one feature that will occur always late would be a development of Sydenham's chorea. So the alphabet S in this mnemonic, is basically Sydenham's chorea. While I'm writing it, the question to you guys is Sydenham's chorea, the antibodies which are formed in rheumatic fever will act against which basal ganglia? Then I think all of you are aware of the fact that it is the caudate nucleus that would be affected, and this will cause fast distal involuntary movements. Chorea is always a fast involuntary distal movement in the hands of the patient. In contrast, ethiotosis also occurs in the hands. It is also a distal movement but is very, very slow. Hemibalismus would be a ballistic movement at the shoulder. Hemibalismus would be a proximal. Hemibalismus involves proximal and distal both, but predominantly it would be a proximal flinging movement of the arm. So we call it a ballistic movement that is occurring in the arm. That would be hemibalismus. But chorea and ethiotosis both occur in the distal part. The difference between the two is chorea is a fast involuntary semi-purposive repetitive movement, and ethiotosis is a slow movement. After describing carditis, arthritis and syndrome's chorea, the remaining two are easier to remember and are very unlikely to be asked. Alphabet E would stand for erythema marginatum, and then the next alphabet S would stand for subcutaneous nodules, and these subcutaneous nodules would be in extensor distribution. Once we get the major criteria right, I'll mention the names once again: carditis, then arthritis, then syndrome's chorea, erythema marginatum. Erythema marginatum is not encountered in Indian population because we are darker in texture, so there are usually no questions on that. And then do remember, it's not erythema nodosum, it is erythema marginatum, and you guys are smart guys, you won't make a mistake in that. And then would be subcutaneous nodules in extensor distribution. Then comes the minor criteria where even laboratory features are incorporated. So there would be presence of fever anyway because it's an autoimmune disorder, inflammatory disorder. Then there would be changes in ESR. Every time there's an inflammatory disorder, ESR will also come in the picture. Now for the ESR, what he has done is, when I was a student, he just to say elevated ESR, but now he has even mentioned values. So let us just look at the values in this case. He says for a country like America where disease is relatively less common, ESR of more than 60 would be considered. But for a country like India where the disease is relatively more common, ESR of 30. Why they have taken lesser is because disease is more common in India. So even if it has not risen to the value of 60, I would still consider it to be a diagnostic criteria. Then would be elevated CRP. So a change again here is that when I was a student, total leukocyte count, TLC, was a diagnostic criteria, but now TLC is not included in the Jones criteria for diagnosis. And apart from these two, ECG would be showing a prolonged PR interval. This prolonged PR interval will be occurring primarily because there would be development of Ashkoff nodules between the SA node and the AV node. So it will slow down the conduction between the SA node and the AV node. And because of the slowing down of the conduction in this case, there would be a prolonged PR interval. Normal PR interval is 120 to 200 milliseconds. Here there would be a slowing, there would be a prolongation of the PR interval that would be coming up. So for diagnosis of rheumatic fever, we would be requiring two major features, one major with two minor, and they also put up when would you consider three minor criteria to be diagnostic, that is for recurrence. You can see here in the table as well, when it comes to the recurrence, even three minor alone would be sufficient for identification. But for the initial episodes of rheumatic fever, for diagnosis, we need the standard information, that is two major and or one major plus two minor criteria. Apart from this, even ASO titers in these patients would be considered. That is one of the important tests that has to be done, because elevated ASO titer gives you indirect evidence of the fact that there was a preceding streptococcal infection. Now, once we get these features in place, then the treatment of these patients would be initiated, and in the treatment part, he can ask you regarding what are the steps to be taken. So for the arthritis component, the drug that will be used will mainly be aspirin. And there is one of the side effects of aspirin that we always study, though is relatively less common, that would be seen if aspirin is given with a viral illness. With influenza B infection, then it can trigger a Ray's syndrome where the liver of the patient can be damaged. There could be hepatic encephalopathy, there could be brain damage as well. Then another weapon that you could be using is steroids. Steroids would be used, one, in cases of arthritis if aspirin is not working, or steroids can be used for pericarditis. They'll reduce the inflammatory component in the outermost part of the heart. But do not answer steroids if there is going to be pulmonary edema. Like if he says myocarditis, first episode itself causing myocarditis, causing heart failure, then we have to go in for LMNOP, Lasix, morphine, nitrates, oxygen and positioning that I've discussed in the earlier part of the app with respect to, in this section only in the rapid revision, I've talked about it with respect to congestive heart failure. Then as far as chorea is concerned, chorea is mainly self-limiting. So I'll just write the word self-limiting here to highlight the fact that we usually do not try to treat chorea because the manifestations disappear in 3 to 6 months. But if it is very disabling, we might have to start medication. What are the medications that you could be using? If the chorea part is disabling, you could be using valproate or you could be using haloperidol. And when I am describing these drugs, the enthusiastic mother can ask you also, sir, if you have drugs available, why are you not prescribing? So you will say, ma'am, if I give these drugs to your child, he will start having side effects. Like haloperidol can cause drug-induced Parkinsonism. You see, the basic essence of medical science is first to no harm to the patient. Just to treat one symptom, I cannot cause another disease. So chorea is self-limiting. We can be using the drugs which I've mentioned here before you. And if even if this is not working, then even steroids would be useful for management of chorea. And if nothing is working, we can even be using intravenous immunoglobulins. My point here is that we have a treatment available for these patients who are suffering from chorea, but this would be reserved only for extreme cases where it affects the quality of life, where the child can't even eat because of the chorea component. I mean, the disability component will decide whether or not would you be treating this case per se. Now, when it comes to patients of rheumatic fever, they can have a recurrence of infection as well. So we will always read about injections of benzathine penicillin. These injections of benzathine penicillin should be given 3 weekly. Like usually we read about 1.2 million units being used, and pediatric age group, if the age of the weight of the child is less than 27 kg, you might even read about 0.6 million units also being used. So I'll just write down the traditional fact that you would be using these injections. They would be given every 3 weeks, and the objective here is secondary prophylaxis. The objective is that we want to, obviously, whatever is the residual infection in the throat, we can get rid of it, but it's going to prevent the redevelopment of sore throat, because every time there's going to be a sore throat, more antibody will cause more damage with respect to the heart, with respect to the joints, with respect to the skin manifestations. And even if, let me say the damage is already there, it will worsen that pre-existing damage. So mitral regurgitation, if it was present initially, if it was mild, it might become moderate to severe. So I don't want worsening. Therefore, shots of benzathine penicillin should be given regularly. And obviously, when you prescribe penicillin because of the risk of anaphylaxis, it should always be given after a test dose. Now, with respect to the duration part, they can ask you what is the duration for which the secondary prophylaxis with benzathine penicillin would be given in the patient. See, the ideal answer is lifelong, but lifelong is not practical. Lifelong is not practical. So they could put up options like 18 years, 21 years, 25 years, and 40 years. So let me describe it to you with respect to a case. Suppose there is a mother of a 5-year-old child, and she says she's lamenting before you, my child is so sick, he's having heart failure also because of mitral regurgitation. You did manage it successfully, but she says, sir, how long should the injections be given in this child who's already developed a valvular lesion? Then the answer of yours would be at least till 40 years of age. And if she's gonna be, saying, come on, doctor, that's not very practical answer. 40 years of age, I mean, my kid is 5 years of age, you expect till 40 years, 35 years, you want me to bring my child regularly to your clinic. So you'll tell her, okay, ma'am, no issues, at least till 10 years from the diagnosis of the disease. So, 10 years from the onset, whichever is longer. Now, this statement I'll just write on the top, because every scenario that I'm going to describe you, whichever is longer is the common statement, which is important, because as a doctor, you want to maximize the protection of your patient. Now, there is a possibility that he might mention regarding rheumatic heart disease, but he may not mention any evidence of valvular damage. You see, the second statement that I have mentioned here before you means that there is rheumatic carditis present, but it is not a guarantee, that every time a valvular lesion will develop. Like I told you, there could be MSMR, but it's not necessary every time there's a MSMR. No, it could only be pericarditis. It could only be myocarditis. So in this case, the injections would be given till 21 years of age or 10 years from the onset, and whichever is longer. This was asked in this time's NEET PG May 2020 that if a child is having rheumatic fever, and he mentioned that rheumatic fever without evidence of carditis, how long should injections be given? Then in these circumstances, the injection should be given at least till 21 years of age, or the minimum is 5 years from the onset per se. In fact, here I can say OP says a slightly different aspect. He might mention up to 18 years of age, but the denominator remains uniform. That would be at least 5 years. So your answer according to Harrison here will be either 40 or will be 21. In OP it is mentioned 18 and 25. 18 and 25. So instead of OP I am using here Harrison as a base to mention it. But because there was a question that let us just go through the question also, so that you become much more sensitized to the fact. The question mentioned a kid, the question said that the child has been prescribed benzathine penicillin, and he had himself mentioned regarding the dosage, etc. I mean, you don't need to worry about the dose of any drug per se. They are not going to ask you what is the dose corresponding to the body weight, but they just said which of the following is correct for secondary prevention, and the question said one is lifelong, every 3 weeks. Lifelong is okay. I mean, we do go even for lifelong. Let me say if the child has had a valve replacement, like there was so much of damage, that you had decided to go in for a prosthetic valve deployment, then I don't want to take a chance and end up with the damage to the new valve as well. So in extreme situations, they mentioned even with respect to valve replacement, lifelong would be required, but otherwise lifelong is usually not practical. Option B said only one single dose. Well, that's not going to be suitable because we want to prevent recurrence of sore throats and the residual damage that occurs in the joints. Then we had options like 10 years or till 25 years of age, or 5 years 3 weekly. The correct is what I've just told you here. For rheumatic fever, it is 21/5. The learning point is that for Harrison, either answer will be 40 or 21. Traditional MCQs usually talked about options like lifelong, 20, then 40 years of age, 25 years of age, 21 years of age, or sometimes even 18 given. But in Harrison, they've made it simpler. It is only two values to be remembered by you. Don't get into that OP guy thing versus Harrison, your life will become miserable otherwise. Just get the facts right. Either the answer in the MCQ will be 40 or will be 21, and the backup answers are 10, 10, 5, and this is 5 that was asked this time. I repeat once again, it is 40 and 21. How would you decide? If valvular region is given, answer it as 40. If valvular region is not given, it is 21. You see, it doesn't matter whether carditis or no carditis. But the backup answer will vary, because if there is going to be no carditis component present in the patient, then the backup answer is 5 years, and he decided to ask that. And if there's going to be carditis, then the backup answer is 10 years from the onset. And obviously that whichever is longer is a statement which is valid for all three of them. That is a universal statement, because we want to maximize the reach of the antibiotic. We want to maximize the protection of the patient and reduce the recurrence of rheumatic fever episodes in the patient. Now, next on the agenda would be to talk about congenital heart disease, where we talk about NADA's criteria. So I've described Duke's criteria for rheumatic fever, modified Duke's criteria, modified Jones criteria for rheumatic. Now we're going to discuss NADA's criteria for congenital heart disease, which would be major and the minor ones. Major criteria would incorporate two murmurs, systolic murmur and a diastolic murmur. Now let me just explain to you why the systolic murmur grade 3 is being considered. Let us assume a patient is having tetralogy of Fallot. In pediatric cases of TOF, there would be a ejection systolic murmur, and if it is loud enough to be heard even without a stethoscope, let me say, there's also associated thrill, then it becomes a major diagnostic criteria. And for diastolic murmurs, I can give example of ASD. ASD has a flow murmur, that would be a mid diastolic murmur, so that would become again a diagnostic feature. Another systolic murmur I can mention is for VSD, that would be a pan-systolic murmur. The message is that if the murmur is loud enough, more than grade 3, we'll consider that as a major diagnostic criteria, including diastolic murmurs as well. As far as consideration for cyanosis is concerned, you very well know if it's a right to left sided shunt, there would be central cyanosis. There could be TET spells where the baby will be so blue that he will almost become black. TET spells, the child looks almost jet black, deathly blue color, deathly blackish color of the skin can be present because of a hypercyanotic spell, and we'll talk about the management of that as well. As far as congestive heart failure is concerned, why would it occur? That would be due to volume overloading if there is a presence of a left to right sided shunt. So remembering the major ones are easy. Cyanosis and heart failure are standard features of right to left and left to right, plus presence of both kind of murmurs, systolic as well as diastolic. When it comes to the minor criteria, you will see the word abnormal written lots of times. So I will come to point number 1 also, but you can see abnormal word is coming multiple times, like abnormal second heart sound. Like for example, in tetralogy of Fallot, pulmonic valve hardly moves because there is a subpulmonic stenosis component present. So because the range of movement of the valve is less, very less blood can go into the lungs. If less blood will go into the lungs, that will explain the cyanosis component. And at the same time, because the A2 component will be heard normally, but P2 may not be heard. I'll repeat that again. Second heart sound has two components, A2 as well as P2. In patients of tetralogy of Fallot, A2 will be heard normally because no problems in the aortic valve, but the P2 component might be so feeble. P2 component may be so faint that you hardly may be able to appreciate it, or you may not be able to appreciate it. Because you may not be able to appreciate it, we're going to call it a single S2. So every time you read the word single S2, no, it always tells you that there is a problem with respect to the pulmonic valve whenever I'm talking about congenital heart disease. And in fact, you will notice that in Fallot's physiology, this is one of the important diagnostic criteria. So that is why abnormal second heart sound has been included in the diagnosis here. Then he says abnormal ECG. Well, you know, in congenital heart disease, there could be a chamber enlargement. Like, for example, if it is a ostium secundum variety of ASD, it can contribute to development of right axis deviation. But the ostium primum variety of ASD, what happens is that there is also a cleft mitral valve, and because of cleft mitral valve, what happens is left atria gets grossly dilated. I'll repeat that again. In ostium secundum, blood of the left atria goes to the right atria, so there's volume overloading of the right atria and the right ventricle, and because of this volume overloading of the right side of the heart, you will always encounter right axis deviation. But ostium primum is associated with a cleft mitral valve. The cleft mitral valve will cause leakage of blood from the left ventricle to the left atria. So it will cause a substantial enlargement of the left atria per se, which explains why do you read about left axis deviation in ostium primum ASD. And I explained that because the query of most people is that ASD after all is a common disease here, so it should be producing a universal finding. But what is differentiating what is the parameter which is changing this axis with respect to ostium primum? That is the cleft mitral valve causing a substantial involvement or enlargement of the left atria of the patient, contributing to change in axis. So abnormal ECG with respect to the axis deviation would also give you a hit. Then abnormal chest X-ray, that's easier. I mean, every time you read about boot-shaped heart, every time you read about egg on side appearance or a figure of 8 appearance, so I'll just highlight this figure of 8 or an egg on a side appearance present or a boot-shaped heart in a patient where the apex of the heart is lifted up, then it always gives credibility to the possibility of a congenital heart disease. In fact, the figure of 8 appearance or the snowman heart is what you read with the supracardiac variety of TAPVC. The egg on side appearance is with TGA, boot-shaped heart is tetralogy phallic. Nobody would have an issue with that. And as far as abnormal blood pressure is concerned, abnormal BP values are valid for a defect in the aorta. If a person is having coarctation of aorta, then the problem in coarctation of aorta will work out to be that because less blood will go to the legs, so the BP of the lower extremities of the patient, BP of the lower limbs of the patient will be relatively less because less blood is going down. In contrast, when it comes to the blood pressure in the upper limbs of the patient, it would be elevated. So the message here is that when it comes to coarctation of aorta, which would be an obstructive defect of the heart. So we're not only talking about a left to right sided shunt and a right to left sided shunt, we're talking about obstructive defects as well, like coarctation of aorta, which has to be taken into consideration, which is why abnormal BP comes into the fact. And then one of the minor criteria would be murmur could be present, but the intensity would be lesser, that it would be difficult to appreciate unless and until it's a very quiet room and the child is not crying. For the interpretation part, you need to have either two major criteria, which could be like heart failure and a presence of a pansystolic murmur. Suppose a patient is gone into at 6 weeks of age, a baby is having heart failure and is having a pansystolic murmur. I could be considering a moderate to large VSD causing symptoms. Minor, if it's a small VSD, symptoms might occur even later also. ASD usually presents by 5 years of age. In fact, congenital heart disease, which might even present into adult age group, is ASD. ASD usually presents at 5 years of age because pressure difference, left atria to right atria pressure difference is very, very less. Because it's a low pressure shunt, the presentation is delayed up to even adult age group. So you could be having two major criteria coming up. That's one important aspect, two major, or it could be one major but two minor criteria. And let's just revise them once again. The major ones and the minor ones would be always having abnormal S2, abnormal ECG, abnormal blood pressure values, abnormal chest X-ray. So that's easier to remember. Major ones are cyanosis and heart failure, standard features. And then it's going to be two more, that is murmurs, either systolic or a diastolic murmur. Why a diastolic murmur? Because it could be telling you regarding a low pressure shunt as well. Now, once we get these NADA's criteria imprinted in our brain, then we look at one of the important congenital heart disease, which would be tetralogy of Fallot. One of the problems in these patients would be a VSD. And another problem that would be present is a concentric right ventricular hypertrophy. This hypertrophy that I've shown here before you is from the inside of the heart, as I have shown, and the blood going into the pulmonary artery would be lesser. There is no problem with the orifice of the pulmonic valve. There is no problem with the blood with respect to the pulmonic valve orifice, but the blood is still exhibiting a problem in going. Why? Because you can see this is like a speed breaker, no useless muscle in the heart. So whenever the right ventricle of this patient will decompress, whenever the right ventricle will contract, you would be having deoxygenated blood going into the left atria. and left ventricle in fact, and this would be meeting oxygenated blood that would come up from the venous return, and therefore because there is a mixing of the two circulations, there would be a central cyanosis. But even more sinister than that, that's the point to be understood, even more sinister or more dangerous than that is that in these patients the blood is having to go across this gradient, and once it goes into the pulmonary artery, because this blood is going across this relative resistance that I said, which is not at the level of the valve but before, so subpulmonic stenosis is actually the major determinant of cyanosis. The MCQ was, what is the major determinant of cyanosis in tetralogy of Fallot? So a lot of people answered overriding aorta, some people answered ventricular septal defect, which obviously is a contributor. Overriding aorta is a contributor. I mean, overriding aorta means that it is receiving blood from both the left ventricle as well as the right ventricle. It's a mixture of the blood from the left as well as the right ventricle. But if you look at the major determinant of cyanosis, it is subpulmonic stenosis, because it is the limiting factor which will restrict the amount of blood going into the lungs. There are a total of 4 defects which are present here. I'll just enumerate the names and then I'll talk about TET spells. We have a VSD present here. Subpulmonic stenosis is anyway the major determinant of cyanosis. I wrote that again because people miss that word sub. It's written pulmonic stenosis in the MCQ. It is subpulmonic stenosis. Like in HOCM, no, it was subvalvular aortic stenosis. Similarly here. Then there is overriding of the aorta. Overriding here simply implies that the aorta is getting a blood which is mixed of both the left side as well as the right side. And this concentric right ventricular hypertrophy is present since birth in these patients. I mean, the heart of this patient is not designed like a normal heart anyway. This is gonna have a hypertrophy from the inside, which explains the fact that how is it possible for the blood to go from right to left in these patients, because traditionally if a person is having a VSD, blood can't go from right to left. If person is having VSD, no, it will cause blood to go from left to right because pressure on the left side is higher. So the first fundamental issue is you should realize that the blood can go from right to left. Why? Because the right ventricle of this patient is having more muscle as compared to left. Normally left has more muscle. No, here right is having more muscles than even the left. Left is normally developed, but right is having more muscle than the left, which explains the shunting component present here. Now, when this child of tetralogy of Fallot will cry, sometimes he might become so blue that the lips might become black, and that's called as a TET spell. So what happens during TET spell is, and let me just highlight from this diagram, during TET spell, this shunting that is occurring tends to increase. As I said, now more deoxygenated blood is going from the right to the left ventricle. If more blood will, see, right ventricle has a limited amount of blood. If more blood of the right ventricle is going to go to the left, then the amount of blood going in the lungs will further reduce. You can see that I've slightly modulated my line diagram now to show that because majority of blood of right is actually going to the left ventricle, the amount of blood going to lungs would be lesser. And if the amount of blood going to the lungs would be relatively lesser, I want you guys to give me a feedback here. I know it's a recorded class. I'm trying to give a semblance of a live one. So do comment here, guys, what is going to happen to the intensity of the ejection systolic murmur in these patients. If less blood will go, will the murmur become louder or will it become softer? I think I made my point there. In patients of tetralogy of Fallot, we have an ejection systolic murmur, but during a TET spell, the murmur tends to fall silent, in a sense that the murmur becomes softer. This was itself a MCQ. This is a previous actually AIMS MCQ, and I think even was asked in FMG exam, though in a different way. But then the point is that because now less blood will go to lungs, that explains why cyanosis is worsening. There are two reasons why cyanosis is worsening. More blood going from right to left, right ventricle to left ventricle, less blood going to the lungs. And when the lips are almost going black, jet blue to black, that is when the murmur will become relatively softer. In fact, in patients of TET spell, they've also asked what is the first line intervention. So you will have to take the child to the hospital, but you have to tell the mother, ma'am, please do not keep the baby to the shoulder. I mean, normally if a baby is sick, the mother will pick up the baby, put him to the shoulder, start patting the child, as we normally do whenever a child is wailing or whenever a child is crying. Here you will tell the mother, ma'am, please place the baby in knee chest position. Knees should be touching the chest. So how to ensure that? One is let the baby be supine and flex his knees so that the knees touch the chest. That would be cumbersome because you will have to continuously hold the legs of the child. So better way is turn the child prone And when you turn the baby prone, this is what I'm saying, when you turn the baby prone, the baby will be on his knees. So maybe my diagram is looking a little crude at the moment, but my point is that you have to turn the baby so that the knees of the baby would be touching his chest. So knee chest position is the first step in management of these patients. And then subsequently we use multiple drugs. We use a non-selective beta blocker like propranolol, and we also use vasopressors in this case to terminate our TET spell. And you can read more about TET spell from the pediatric domain as well. But then do remember about the drugs that we're using here. I mean, we might even have to use morphine in these patients. It is knee chest position, it is propranolol, and then we even give vasopressors in these patients so that we can reduce the shunting which is occurring from the right to left side in the heart of these patients. This, guys, is an important concept with respect to tetralogy of Fallot. The 4 defects is what I've shown here. And suppose he wants to ask you regarding pentalogy of Fallot, PUF. Then in pentalogy of Fallot, these 4 defects will anyway be present. But what would be the additional defect in pentalogy of Fallot? The additional defect would be a presence of a ASD. So, I mean, sometimes they can just play around with these numbers like tetralogy of Fallot or pentalogy of Fallot. So, you should be ready with that. And even in pentalogy of Fallot, if he says what is the major determinant of cyanosis, your answer in those circumstances would still be given for major determinant of cyanosis as a subpulmonic stenosis. Now, I'll just draw one more line diagram here with respect to tetralogy of Fallot just to get a point across. So please be patient and listen to this fact. In fact, this will have a bearing with respect to the age of presentation. When does tetralogy of Fallot present? The baby does not turn blue right on day 0 of life. The baby turns cyanotic usually by day 7. Let me give a explanation of the same with the help of this line diagram. What I've drawn here is this is the pulmonary artery, this is the aorta of the child, and then I've shown this concentric right ventricular hypertrophy, which is contributing to the limitation of the blood going in the lungs. And as I said, deoxygenated blood is ultimately going to reach into the aorta of this patient and into the systemic circulation. Like all babies, this baby will also be having ductus arteriosus. Ductus arteriosus connects the bifurcation, mark my words there, ductus arteriosus connects the bifurcation of the pulmonary artery to the descending aorta, and this ductus arteriosus at the moment after birth is patent. You see, ductus arteriosus would not close immediately. It will take some time for it to close, and the usual closure, functional closure, occurs by 7th day. So before the 7th day, this is what will happen. The deoxygenated blood will move like this also across the ductus arteriosus because of the pressure gradient. No, aorta pressure. The aorta pressure will be more than the pressure of the pulmonary artery. So this deoxygenated blood is going towards the lungs. All this blood that will ultimately reach the lungs of this patient will get oxygenated, and all this oxygen rich blood will come into the left side of the heart. So what is ultimately happening is oxygen rich blood is still coming to the left side of the heart, because of which I write the words here, oxygen rich blood is still coming to the left side of the heart. So cyanosis in these patients may not be noticed. But on the 7th day of life, I'm now going to put a cross here, on the 7th day of life, when this ductus arteriosus will close, then this blood that was coming by the ductus arteriosus will stop. Routine blood from pulmonary artery would be coming, blood would also be coming like this, like the blood, when the right ventricle will decompress, some blood will come like this also into the pulmonary artery. So whatever blood is coming from the right ventricle via the pulmonary artery towards the lung would still be coming, but this ductus arteriosus additional supply would be gone, which is gonna now reduce the amount of oxygenated blood. By these dotted arrows, I don't mean that the total amount of blood coming is lesser. Yes, physically the amount of blood would also be lesser, but more importantly, the saturation will drop. Why saturation will drop? Because now all the blood coming by the ductus arteriosus by the circuit won't be present. Only the one that is coming like this. In fact, I should use an arrow here. All the blood that will go like this towards the lungs would still be present. The blood is coming from the right ventricle, just like in you and me. But that additional supply from the ductus arteriosus is gone. So therefore, the reason why we've done this is to tell you that if you read a question that begins by saying central cyanosis in a baby on day 0 of life, then the answer is not a tetralogy of Fallot. In tetralogy of Fallot, the central cyanosis will develop on day 7. In fact, I can put this as a question to you guys, since I presume you might have completed pediatrics. If not, I'll anyway give you the answer also. Central cyanosis in a baby on day 0 of life. Yes, guys. Central cyanosis in a kid on day 0 of life, the answer would be given as TGA, that is transposition of great arteries. In tetralogy fillet, it would be on day 7, plus he will also give you auscultatory finding, that is a single S2 present. The intensity of this will become lesser in a TET spell. There would be a ejection systolic murmur in these patients as well. And more importantly, if he decides to give you boot-shaped heart, never an issue. The only thing is sometimes they use these terminologies like Latin ones like coer and sabot. So doesn't matter. I mean, whether he says boot-shaped heart, he talks about coer and sabot, it's still gonna be tetralogy of Fallot. If it's day 0 of life, then it's transposition of great arteries. And then a twist in the question was central cyanosis in a baby on day 0, and the cyanosis increases with crying. And another MCQ was central cyanosis in a baby on day 0, and it decreases with crying. And that though I'm getting a little off medicine here, but still our objective is to keep the strike rate high. So that is why this question was I have decided to handle these questions. Cyanosis in a baby, central word may not be given, but still, I mean, it implies lips would also be blue, fingertips would also be blue, and the cyanosis is increasing with crying. Well, the logic here is, if the cyanosis is increasing with crying, what is happening is that this child is having a diaphragmatic hernia and the stomach is in the chest. And when he will cry, the air will go in the stomach. When he will cry, air will go by the esophagus into the intestine, into the stomach, and the stomach will expand, and the stomach is in the chest. So it will press on the same-sided lung and the cyanosis part will worsen. So in congenital diaphragmatic hernia called Bogdalak hernia, we find cyanosis worsening on crying. On the other hand, if cyanosis is decreasing with crying, then the point is babies are obligatory nose breathers. So if he's having a choanal atresia, he would anyway be blue. He will be having cyanosis present, but when he will cry, some air will still go inside and the cyanosis part will decrease. So you need to read about these topics even from pediatrics and choanal atresia, even from ENT. But the main message here was that congenital diaphragmatic hernia versus choanal atresia also have been asked in the exam, though this went a little towards more of pediatrics. But then the point is our strike rate because in exam it does not distinguish between the subject per se, he just tries to focus on your strike rate. So I thought I'll just that's the justification why I'm discussing this aspect here. So when it comes to congenital heart disease, it's a pure pediatric domain, but I've tried to do justice. And from this line diagram, I also want to highlight why is it that they teach you that in tetralogy of Fallot, alprostadil should be given, because what alprostadil will do is it will keep this ductus patent. And if you will keep the ductus patent, then blood will continue to go inside the lungs and the cyanosis will not occur. Alprostadil, if started early in tetralogy of Fallot, it can prevent the development of central cyanosis. Obviously, in tetralogy of Fallot, you require corrective surgery. You will require Blalock-Taussig shunt. In Blalock-Taussig shunt, they might be connecting the subclavian artery to the pulmonary artery. When you connect the subclavian to the pulmonary artery, blood supply to lungs will increase. Palliative surgery would be done. Corrective surgery, 2 years. You do palliative surgery, that is called as Blalock-Taussig shunt. I'm not writing the name here because that's given in pediatrics. But BT shunting is a palliative surgery. But before that, what drug can be used right after birth in tetralogy of Fallot? And how would you diagnose tetralogy of Fallot right at birth? Because cyanosis will occur after 7th day only if the mother has got an antenatal ultrasound done. Like a lady got ultrasound in the 3rd trimester only. Lots of time hota hai na, poor patients, they get one ultrasound done, baby is having congenital heart disease, you can't do anything. Abortion can be done only after upper limit of 24 weeks. So the point is, if ultrasound was done in the 3rd trimester and it was known that she's having TOF, right at birth, if we start alprostadil, we can prevent deterioration of these patients. Though in India, lots of times this detection may not be done and the child will present to us only when the manifestations become severe.